Ali was born on November 28th, 2011. When he was 3 days old, we were getting ready to leave the hospital, and his pediatrician came in for one last check, and that's when he heard a heart murmur. Several hours later, they tell me that our son has a heart defect and that he had a VSD.
Initial surgery was a success. At the end of the day, he recovered quickly, had no reason to think that we weren't just going to move on to living a pretty normal life.
Unfortunately, when he was 13 months old, he passed away from complications with his heart defect. After he died, we never set out with any goals to start a foundation. We just knew that it felt good to give back. At his funeral services, we had asked that guests bring a donation for heart research in lieu of flowers. In just 2 days, we raised more than $13,000, and we were floored by everyone's generosity. From there, it just kind of grew organically. It made us feel good. It helped us manage our grief a little bit. It kept our minds busy. Doing this work through what now has become the Ali Hinkle Heart Foundation was one way to put that love back out into the world and pay it forward to other families whose struggles we knew firsthand. Part of it was just thinking of what did we need when we were in their shoes, when we were fighting with Ali when he was still alive. We've just set out to create that. The Ali Hinkle Heart Foundation is dedicated to meeting the unmet needs of heart families and transforming the landscape of pediatric heart care. We have community outreach to help wrap them in love, help meet their basic needs. And then we also started our flagship program, which is now called Ali's Branch. And that provides free mental health support for heart warriors, their parents, their siblings, grandparents, the entire family unit, because pediatric heart disease, it affects the entire family. Ali's Branch was created to remove all barriers to accessing mental health support. If there had been different technology in place during that time, Ali might still be here today. So we were very passionate about funding advances in technology and research that is improving the outcomes of children with pediatric heart disease. One of the things that we get most excited about in the technology space is the use of artificial intelligence in the ICU setting. Fortunately, because of the advancements in the pediatric heart space, kids who are born with heart disease are living longer and even living into adulthood. So even though these kids are living into adulthood, it's not just about surviving, it's about thriving. And we are building programs that are supporting these patients and their families for their lifetime. I think that in our experience and with so many families we've met now over the last 10 years, we've learned that pediatric heart disease is something that can happen to anyone. Our vision is to eliminate the traumas that heart families face and to wrap all heart families in love. There's so many different needs for these families, and we're dedicated to meeting those needs.
Hello, welcome to Take Heart 2024. We are your hosts for today's event and tomorrow. I am Sydney Philpott-Strife. I serve as Director of Programs for Ali Hinkle Heart Foundation, and I'm also an adult heart warrior.
Welcome, everyone. My name is Laura Watson. I serve as the Education Coordinator for Ali Hinkle Heart Foundation. I'm also a registered nurse, and I have spent most of my nursing career in the pediatric cardiac world.
Thank you all so much for joining Ali Hinkle Heart Foundation's 5th annual Take Heart Conference. A lot of energy and planning goes into making this event both educational and engaging for heart families and healthcare professionals. We're so excited for what we have in store this year. Just a few quick housekeeping notes before we get started. Because of all the amazing content this year, the conference is spread out over 2 days today, Friday, October 4th, and Saturday, October 5th. Today's session will run until about 3 p.m. Central Time. Tomorrow, we'll get started promptly at 10 a.m. Central Time and should wrap up around 12:30 p.m. Central Time. I want to draw your attention to the boxes located to the right of the video window. The bottom box is a general chat for you all to share comments and engage with other attendees. The top box has two tabs. The first you'll see is a Q&A, so please feel free to type your questions there at any time, and we'll be answering those throughout the conference and during our Q&A sessions with our speakers. For any questions we're not able to get to during the conference, we'll make note of those and reach out to the speakers afterwards to collect responses and share those with all of you. The second tab is your tech support tab. That's where you can reach out if you're having any technical difficulties. Underneath the slide section, you'll see a few links. The top one is our evaluation survey that we'll ask you to complete at the end of the conference on Saturday. But if you have to leave early or you're only able to join for today, please complete your feedback whenever you get a chance to. We'll also be sharing this out via email a few days following the conference. You'll also see in your links that we have our agenda listed as well as all of our speaker bios, so please feel free to take a look at those.
As we prepare to begin with our content, we want to take a few minutes to just share a couple of things with you all. This year's content is organized a little bit differently than it has been in years past. Instead of running through the agenda from one section to the next, we've intermixed the topics throughout today and tomorrow, as a way of acknowledging how interconnected and somewhat interdependent all of these topics are with one another. You will notice the presentation topics flowing between technology and research, mental health, and community education. We invite you to learn alongside us in all of these areas. We also would love to connect with you throughout today and tomorrow, so please take pictures and share your thoughts with us on the socials. Make sure to use the hashtag TakeHeart2024. In an effort to continue growing our community, building bonds, and sharing resources, we invite you to join our Oath for Families Facebook group. This is a great place to stay up to date on all the happenings at Oath and ways we support heart families, as well as offering a place for you to make connections. Lastly, we need to take a moment to thank our amazing sponsors. Without their support, we would not be able to put on such a successful and meaningful event. We are so grateful for your generosity and engagement, so huge shout out to all of you.
Before we jump into our agenda, which we will begin in just a moment, Oath has undertaken a project over the last year and a half to reconsider and redefine the phrase heart warrior. Oftentimes, children with childhood onset heart disease are expected to be brave or tough it out, and these concepts didn't really feel authentic or representative of the true lived experiences, nor did they acknowledge the trauma endured by living with a chronic. So instead, we've redefined the term to say, heart warriors dare to drop the armor that protects them from feeling vulnerable, embracing their lifelong condition to bring purpose and meaning to their lives. They know that they are so much more than the diagnoses given to them. They own their story and are seen for their ability to be brave and resilient when they cannot control the outcome. Their courage is born from their vulnerability to ask for help and support when needed. So through this effort, we have redesigned our warrior cards. Some of you may have seen these already, and we're in the process of collecting and growing our stories. If you would like to submit yourself or your child or another family member as a heart warrior to have their story featured on our website, possibly through other channels, we've also been working on mailing out these cards to those that submit their stories. Please follow the QR code that you see on the screen. We'll also pop this link in the chat for you. So that when we move the slide, you can still keep checking that out. Okay, we have a full schedule today, so we're so happy you've joined us. And thank you again, and welcome to Take Heart 2024.
We are going to begin our conference agenda with a session on technology and research. Ollie Hinkle Heart Foundation is dedicated to supporting, uplifting, and spreading awareness of projects and tools that are truly on the cutting edge. Today and tomorrow, we will hear talks that touch on what we call the 3 Ps: prediction, prevention, and precision, which are our major focus areas within tech and research at Oath. We're going to start today with a presentation from Dr. Brian Soriano in prediction. Dr. Soriano is an attending physician at Seattle Children's Hospital and associate professor in the Department of Pediatrics at the University of Washington School of Medicine. His clinical research interests include cardiac MRI and advanced echocardiography imaging, such as 3D echocardiography. Today, Dr. Soriano will be telling us more about an exciting new diagnostic technology called VentryPoint. an AI technology that transforms ultrasound scans into MRI quality images of the heart in minutes. To all of you listening, please remember to put any questions you may have in the Q&A box located on your screen. Dr. Soriano, welcome, and thank you for joining us today. I'm going to let you take it from here.
Okay, thanks, Laura and Sydney. Can you hear me right now? Just want to make sure my connection is good at this point. I'm going to assume it is. We did a little bit of a check before. So again, thank you, Laura and Sydney, for having me here, and thanks to the foundation for having me. I feel very honored to be the opening presenter for the Take Heart conference. So I'm going to move on here and have a couple of slides to show. I have some disclosures. I'm not receiving any kind of compensation or honorarium for this presentation, either from the foundation or from VenturePoint itself. I'm simply a consumer of the VenturePoint AI technology in the clinical space. So an overview, I'll give a couple more bullet points about myself. And in order to really understand the VenturePoint technology, I really need to zoom out a bit to really talk about imaging in general. That includes things like echocardiography and includes cardiac MRI. I'm also going to assume that I'm sure there are people that have experienced undergoing an echo, an ultrasound, or an MRI. I'm actually going to talk about it with the presumption that you've never experienced it. And I'm actually going to kind of talk a little bit about these other technologies. And then last but not least, really talk about 3D echocardiography and how VenturePoint integrates itself into our clinical care that we have at the hospital. So about me, again, my name is cardiologist. My training was actually in both for internal medicine and pediatrics. I finished that residency in 2000. Got certified both. I had to let the internal medicine go in 2000, mainly because I am focused on children now. My pediatric fellowship was at Boston Children's. I finished that up in 2007. And usually fellowship is for 3 years. A lot of people spend an extra year training in some subspecialty, and in my case, I spent a 4th year focusing in non-invasive cardiology. And that's ended up being a kind of a catch-all phrase for anything that involves cardiac imaging, including VenturePoint, including 3D echocardiography. And then after I finished up the fellowship, came straight to Seattle, took a position here in 2007, and I've been there ever since. So if you're a heart patient being seen by a provider, be it a cardiologist or an advanced practice provider, there are lots of different ways we do assess patients. And it's not just within the heart space, it's within any kind of clinical space in general. You may be aware that there is a history in physical. So when you come in to see a provider, they will ask you about your story, your personal story, your medical issues, a lot about your history in general. There's the examination, the physical examination, where people will listen to your heart, your lungs, check out different parts, not just the heart itself, but different parts of the body, since they're all connected to the heart. After that, lots of different tests, of which VenturePoint is going to be one of them. And I'm saving the best for last, so this will be closer to the end of the talk, but I want to give the background for all this. I like to look at the heart like a house, and this is what I tell my family, is that the heart as a house has lots of different parts to it. There is the plumbing, there's the valves, there's the wiring. So for example, in the middle bullet point, electrocardiogram. So we use that to measure the electrical activity of the heart and to measure the rhythm. Finally, last but not least, there's imaging or echocardiography and other forms of imaging. So our workhorse is something called a 2D echocardiogram. It's also called cardiac ultrasound. And what cardiac ultrasound does is it helps look at the plumbing of the house, but it'll start to kind of play itself back and forth. So I apologize for that little blank spot. But what you'll see in the brief motion images is a picture of the heart by 2D or two-dimensional echocardiography or ultrasound. And what it is basically one small part of the heart in two-dimensional space. In other words, if you have like a piece of paper, you're putting it down on the ground or on the screen, and that is one small part of the heart. I'm going to move on a little bit and talk about cardiac MRI now. And what that is cardiac magnetic resonance imaging. So this is another form of picture taking. If any of you in the audience or on the calling list have like experienced cardiac MRI, more likely than not, you've had other tests like ultrasound in the past. So you have a sense of what the difference is between these two kinds of tests, especially for the patient that has to experience this. Why do we use it? If there was a magic way for us to actually check the heart with just a magical button, a magic wand, a tricorder, I'm like doing all these different citations, we can get everything all together at once. Unfortunately, we can't. So each test that we choose has different reasons for it. So for cardiac MRI, again, magnetic resonance imaging, we use it because we don't answer or can't get all of our questions answered by echo alone. We tend to use this in larger patients. So for those that actually are going through the Heart Warrior experience, you know, as you get older and bigger, it's a little bit harder to use ultrasound to get pictures of everything that we need to know about the patient and their heart. So instead, we have to employ other tests like cardiac MRI. So we use it in larger patients. We use it for complex congenital heart disease. So if we want to look at structures, we want to look at all the blood vessels in the chest, things that the ultrasound or echocardiography can't check. Here's the last bullet point. We actually use it for quantification. Big word for just measuring numbers. A lot of the cardiologists, including myself, we like numbers, and we like to use those numbers to predict when someone is going to need something done. We need that to predict whether they're going to have a procedure or maybe not, which I'm sure is what everyone prefers. We also want to use quantification by MRI to measure things like how valves are working. Are they leaking a lot? If they're leaking a lot, and if you're a tetralogy FLO patient, you know that's one of the things we look for. We want to know how big the heart is. I'm going to kind of go off script a little bit to talk more about what does that mean, how big a heart is, because this is relevant for Ventripoint. We want to know almost down to the quarter teaspoon or the milliliter, like how big a heart is sometimes. 2D echocardiography is really more of a gestalt. We kind of look at the picture and say, yeah, that heart looks big, that heart looks normal, that heart looks small. But we don't have the precision that we would need sometimes. That's why we do cardiac MRI. Here's the downsides of MRI. It is a very long test, 45 to 90 minutes. If you've had an echocardiogram, you might just say, well, hold on, Dr. B, that's about the same time. One of the downsides about cardiac MRI is that you have to stay supine. So that about 4 bullet points down, you need to stay supine. That's a fancy word for saying lying flat for the whole duration of the cardiac MRI. You have to hold your breath too. So you have to be able to follow instructions. If you're prompted to say, okay, hold your breath while we take the pictures, that's what we need for MRI. Did I say you have to stay supine for a while? Yeah. Can you imagine that some of our youngest patients can't really lie flat in the MRI for 90 minutes? It's not easy, even for grown-ups. The last part is a very noisy test. It's not the best experience for a lot of patients because it's very loud. The kind of machinery or the hardware that's needed to create some beautiful pictures, it's not going to be straightforward or easy. This is like my one picture. I'm going to spend some more time showing you what it looks like for those that have not experienced being in a cardiac MRI suite. So where we are now in the picture is what's called the control room. It's actually a space where the MRI itself is outside of where the MRI is located. If you notice in the picture, there looks like a double pane window right in front of the computer where that woman is sitting in the left-hand side of the screen. That window is a literal view to where the MRI is. And you can see a round donut. And believe it or not, there's actually a patient in the middle of that small circle. You can kind of see their feet in that picture there. So they slide in there. There's a lot of noise. They're wearing earplugs. And we're taking these pictures. It's not the most fun environment for a lot of people, especially for adults that are claustrophobic. You can only imagine what it'd be like if you were a younger child trying to have to go through all of this. I didn't even mention the things that, like, they sometimes need an intravenous line to have these done. But with that, we actually can get a lot of great pictures here, including that quantification I was measuring, or I'm sorry, what I was talking about how big, how small the heart is. But these are some examples of the pictures here. I'm just going to kind of go through these pictures to show you what it looks like. But really moving pictures here, and I think there's some comments about whether people can see it or not, but I'll just have to keep on stepping through it. I'm going to step through the still frame here. So this is a larger heart. I don't have a picture here, but you can see what looks like a crescent moon. That is the right side of the heart of the right ventricle. The heart can get really big, and this is what we want to know sometimes is, yes, by echo, it looks really big, but we want to know, all right, just how big is it? Are we talking about, 400 mLs or 400 cc's? Is it 500 cc's? 2D echo cannot do that. MRI can. Venture point can as well. We'll get to that actually. There's another quick cine image. Maybe if we can just let that play once or twice more. This is what we see by cardiac MRI. And then I'm going to step after we played it one more time. These are the pictures here. I'm going to show one more 3D image. This is the vessels of the chest actually, and a little bit of the kidneys here. But this is what an MRI does. This is information that MRI can supply that echo can't. I just wanted to show this because this is what to expect when you get an MRI done. On to the really important part, which is venture point, which is a form of 3D echocardiography. So it's not like the movies. We're not wearing glasses to try and see things in 3 dimensions, but we are actually constructing the heart using 2-dimensional echo images. So the venture point or MRI or 3D echo, all of these modalities complement themselves. They're not meant to replace one or replace the other. Really, as clinicians, we like to have as many arrows in the quiver as we can to really sort things out. So 3D echo, including venture point, is incorporated into our standard examination. So what does that look like? I just want to show you some quick 3D echo pictures first. This is where we take the 2D picture and turn it and add that third dimension, add more depth, add more volume to it. We'll let this play once or twice more. This is actually a picture of the tricuspid valve. I'll show you a still frame picture, but if you focus on the left-hand side of the screen, there's this crescent moon shape that I was referring to, and that is the right ventricle, and part of it is a tricuspid valve. I'm going to move to the actual still frame so you can see what I was referring to, but that's the portion that looks like little strings or leaflets there. I don't have an arrow pointer, but that's really the gist of 3D echocardiography. We'll skip that. I'm going to give one more movie here, and this is another example of looking at 3D echo. So what we're seeing here is actually what looks like a walnut, but this is actually a cross-section of a left ventricle. And for those that are in the know about imaging, you'll notice that this ventricle is not squeezing well at all. It basically looks like it's just kind of barely moving or rocking. The image itself is moving back and forth to show you the inside of this walnut of a ventricle. But this is what 3D echocardiography does. This is what we do to measure the size or volumes of patients. I'm going to move on here. So really the gist of things, and I appreciate your patience. Venture point, artificial intelligence, echocardiography. So it's really a hybrid. It basically is kind of a bridge. And when I talk about this, I'm speaking as a clinician more than a researcher. There are clinical benefits of how venture point can integrate itself into our care. And it is sort of a bridge between MRI and our traditional 2D echocardiography and 3D echocardiography. So the way venture point works, and I'm moving on to the kind of the images here. My understanding is a little bit later on in our day, there's actually going to be a really nice video. Honestly, it actually shows venture point better than I'll be able to, but it'll show a video of a patient actually undergoing through the whole process and seeing what the outcomes are. I'm going to give you a little bit of an overview and explain it to it from my context about how we use it in Seattle. But it's a FDA approved device that's approved for all ages and for 4-chambered hearts. It's a quick acquisition. So remember in my slide when I talked about MRI, how it takes like almost 90 minutes? For the venture point itself, if I want to know that quantification part, how big is the heart, down to the milliliter, down to the quarter teaspoon, how big is it? It takes about 5 extra minutes in addition to the echocardiography. It tracks the heart in 3-dimensional space using a lot of these sensors, very small sensors that's used. As far as the venture point unit itself, I'm going to direct you to the picture that's in the slide right now, but you'll see like a little bit of a wire cage and what almost looks like an iPad in the landscape mode. That is the venture point unit. So it's almost like a sidecar to the actual echo machine. And those pictures there is really the setup that we use. So you can imagine if you're in an exam room, this is going to be a lot more comfortable than actually getting an MRI. So the steps to acquire it, we acquire the images using the standard echo machine and that venture point sidecar unit. So what that unit is doing is that it actually tracks where our probe is in 3-dimensional space. So with that extra imaging, and I'm going to see if this video plays here, we're taking that 2D image and we're actually assigning points to it. So all those green crosses, blue crosses, white, that's what the clinician is doing. We're telling the venture point unit, hey, this is where part of the heart is located. And what the unit will say is, okay, I hear you and I see you. Let me draw a yellow line and show you where I think the rest of the heart is. And that's the AI part of Ventripoint. And it's seen in both systole and diastole. That's just a technical point for like how big and how small the heart is when the heart squeezes. But we say this is the integration of the 2D echo with the 3D echocardiography. I'm going to move on to the next slide. This is a citation from a publication that just shows the different contours, because that picture I showed you, the moving video I showed you, is basically one of several images. And we only needed to get about 7 pictures. The contours, the yellow tracings, is what the Ventripoint AI says, okay, I see these images in space. This is where I think the heart is. And in that lower right-hand corner, that's the reconstruction that you'll see. Again, I'm going to keep referencing the video that's going to be shown later on today that actually shows a patient going through this whole experience. This is another video that just showed the end result of what Ventripoint AI does, and that is the 3D model. So this, what looks like a flask here, is actually the right ventricle. And we're just showing how Ventripoint was able to take the 2D images and turn it into this 3-dimensional information. With this, I'm going to move on now from here and just show the end result. With it, we get numbers. And again, that value of quantification, trying to measure how big a heart is to predict when we need to do something, or to predict if there's going to be an adverse outcome, which we actually don't want to have happen. We would want to do an intervention before that. We get the numbers displayed by Ventripoint. These are numbers here, and if you look at some of them, it's 174.8, 113.8 on that right-hand picture. These are the really, really precise measures of how big or how small a heart is. We can't do that by traditional 2-dimensional echocardiography. We can do it by MRI, and now more recently we can do it by Ventripoint, which is actually an amazing technology for us clinically. So how does it really help, just drilling down for the patients and their experiences? Again, it gives measurements of the heart sizes that are as good as cardiac MRI. It takes a lot less time. I didn't even mention resources, both fiscal, time, and space. MRI is expensive. The Ventripoint echo won't be as much. So I can get those actual numbers without having to go through that whole MRI. We can also do it without anesthesia. If you notice the picture where I showed the echo machine and the carts, you're in a quieter, comfortable, if I can actually say comfortable for visiting a doctor's office, you're in a space that is not going to be as loud or obnoxious or confining as MRI. So if anyone's had to lie down for an ultrasound, that's probably going to be a whole lot more comfortable than lying down for an MRI. So because of that, there's less concern or anxiety. You're not going to be in a cooped up space. The last bullet point, again, I'll reference to the future video that you can stick around and watch. It can be used in different settings. So we're not just confined to the clinic room. We can actually use that sidecar of a cart and move it to different spaces to get these Ventripoint measurements. So in summary, I've given you a sampling of lots of different ways we do assess a heart by pictures. We have the 2D echocardiography, which is really our bread and butter for imaging. 3D echocardiography, of which 3D echo is the Ventripoint AI imaging. And again, from a clinical space, I find this very valuable. And we've had a good number of referrals. We have actually really incorporated, I would say it's been about the last year at Seattle, where it really has come into fruition as becoming a clinical step for a lot of the patients that need 3-dimensional or AI imaging. And that's really all I have. I appreciate the time and the opportunity to talk about things. Happy to entertain questions.
Thank you so much. Hey, thanks so much for that presentation. That was really, really helpful and interesting. We had lots of engagement and discussion in the chat and in our Q&A. So I have a few questions that I'll kind of read out for you, and you can tell us what you think. So one thing that you mentioned as you were going through your talk was that you could do visualization of a 4-chamber heart. Is the Ventripoint technology not available for use for those with single ventricle anatomy?
You know, that's a great question. So currently not. I do know that, I'll take another step back here. So in order for Ventripoint to predict how big or how small hearts are, they are drawing on a a data source. That data source is a lot of cardiac MRIs that had been incorporated, and it's almost like the model for the AI to generate the volumes. Those are the four-chambered hearts. My understanding from the Ventripoint folks is that they are working on building a database for single ventricles, for functional single ventricle patients. So in fact, we're actually on a research side of things. So this is my clinician hat talking. I'm going to put on the research hat on now. There is research work at our hospital that is trying to use the current Ventripoint AI data sets to see how well it tracks single ventricle. So this is my long answer of saying that no, it's not used for single ventricles yet. I would imagine from the Ventripoint standpoint that that will be coming sometime in the future. Great question.
A lot of sense. And I'm not sure if you mentioned this during your presentation, but someone mentioned in the chat that this can really open up opportunities for those that have metal hardware, like a pacemaker, an ICD, or something, that they can have Ventripoint technology versus, being excluded from using MRI.
Yeah, that's an amazing comment. I did forget to talk about that or mention that in my slides. Again, I'm going to reference the video that people I hope will stick around to see. But the Ventripoint technology is always evolving, and one of the ways, I didn't mention the sensors, but you'll see that in the video. What's actually a little bit out of date, and I mean that in a good way, is that there is like a block. It's about the size of a small tangerine. There's a block that they have to go on the patient's chest to do the Ventripoint scanning. That block is a permanent magnet. So going to the question about devices, if you have a pacemaker or things, we actually couldn't quite use it yet. That has changed. That block you see in the video is now no longer needed. They actually have a different sensor now that doesn't require magnets. So the point is, yes, for 3D echocardiography and for patients that have contraindications to MRI, like having pacemakers, like having pacemaker wires, permanent or temporary wires that are still in place, you can do the Ventripoint without any problems. So rather than, and I'll take, if I have time to take another step back, for those that have devices, you may be aware of two things. You can actually get a CT, which is a lot of radiation for those volumes, not preferable. You can get MRIs. There are some patients that have what's called MRI compatible units. Here's the downside. The image quality still isn't that great, because even though it's considered like conditional or safe for MRI, if you have a generator up here or a generator, like say in the belly, that's still going to create artifact. And in other words, the pictures still just aren't that great. Ventripoint can get around that too if you only need volumes. There are still things Ventripoint doesn't do. I had shown you that nice 3D view of the aorta, the blood vessels in the chest and things like that. That's not what Ventripoint's for. So if you need that information, you're still going to get a cardiac MRI or a CT. So it's not a replacement, it's a complement. So yeah, I'm glad someone did bring that up about pacemakers. In fact, we're getting some referrals already for those patients where they would normally get a CT scan, they'll get a Ventripoint scan instead.
I think that goes to another comment or question that came up is how often do you use this in your kind of day-to-day when you see patients? What percentage maybe are you using the Ventripoint technology?
Yeah, we currently, one of the things about the workflow is that we have to have specially trained individuals, and the Ventripoint is going to be used in definitely a smaller proportion. We do have about a half day where we do Ventripoint scans. In other words, we allot times so that the people that are experienced, both sonographer and cardiologist, are available. And we do about 1 or 2 Ventripoints a week on average now, and I can only see that expanding. One of the things that is going to be sort of the need to how should I phrase it? Having people wanting to utilize it more is just really awareness. So sort of how I'm talking about it here. That's one. And two, clinicians are understandably very wary about new technologies. They want to see like just how good it is and how it can help them. I will say very comfortably for our pulmonary hypertension patients, we're seeing quite a few of those patients to get the numbers for the pulmonary hypertension group. They use MRI quite a bit to measure their right ventricle, the right heart, and they're realizing that having the Ventripoint numbers is, again, another helpful tool for them. So we're doing at least like one or two a week for the pulmonary hypertension patients.
We've got lots of questions, so I think we have time for maybe two or so more. This has been really, really informative and helpful. what additional pieces of information do you kind of typically think come from an MRI that you're not getting from VenturiPoint? And maybe what percentage of scenarios would you say you can use VenturiPoint instead of an MRI? I know you mentioned it's a complement, but can it serve as a replacement in certain situations?
Yeah, I wonder, can people still see the slides also? Because I was going to step to something while I explain this. So it's another great question. I'm sorry, did you say yes, I can, or I can't do it?
Yep, go ahead. You can navigate back if you'd like. Just
Yeah, I see it. I'm just going to show, I can actually explain it well with this one picture. Yeah, that's the video. I don't want to do that because it's going to go away. There we go. So, and I can see the question here, so I appreciate that. Oh, it went away. It was about what percentage of, I think, things that VenturePoint can do, or that MRI is still needed, I guess. So what MRI still is able to do that VenturePoint can't do is look at structures that are outside the heart. So if you need to look at blood vessels, if you need to look at the aorta, which is the giant blood vessel in the chest, and the picture on this right-hand panel is something that's called an angiogram. So that orange color, where it looks like a candy cane, that is the aorta. That is what MRI can do. That's something that CT can do also. That is to measure the size of blood vessels, the overall shape of blood vessels. And you notice I keep saying blood vessels, because that's really what MRI can still do that VenturePoint really isn't designed for. So what VenturePoint does is really to look at the size of the heart. And there are definitely specific patient conditions where the size of the heart is really all that they're interested in. So I mentioned the pulmonary hypertension patients. I mentioned tetralogy of Fallot. That may sound familiar to hopefully some people, where in both conditions, you're really interested in knowing how big the right heart is, that right ventricle. And that's definitely an issue with VenturePoint as far as measuring those numbers. And then to also be clear, there's other ways by 3D echocardiography that can be done. I have, in my just personal experiences, have found that it's actually easier and more thorough to use VenturePoint than more, I can say, traditional 3D echocardiography techniques.
This one kind of goes along with what you were just mentioning. Are you mainly using this for right ventricle information, or are you typically looking at four chamber of the heart, or kind of both?
Yeah, great question too. So for now, the bulk is going to be almost all. I'd say the vast majority is the right ventricle. Historically, VenturePoint was originally built on assessing the right heart to start. So the idea of having, and the FDA approval of having all four chambers quantified is definitely there. It was interesting because I just talked about this at one of our internal cardiology division meetings. We have a lot of new staff on board now, and I was mentioning the four-chamber quantification. And that did seem to have some light bulbs kind of rise among some of the clinicians. So again, to reemphasize, the clinical use of VenturePoint at our institution has really, really blown up, and I mean that in a good way. It has really expanded just in the last year. So we're kind of learning along with everyone else as far as its clinical utility. I can definitely dream up a lot of uses for quantifying the other four chambers. On a practical matter, we just haven't done it at this point. So I think the operative word is not yet.
And maybe this is a not yet question too, but do you know of any utilization of the VenturePoint technology that could be used for creation of 3D printed hearts?
Yeah, that would not be the intent of VenturePoint. So the AI part is that in the kind of artificial intelligence model, there is a set of data already that the VenturePoint unit is going to draw from to make those measurements. So if you're interested in structure, and we certainly are, it's a different pathway and a different approach. This is more the quantification and measuring how big and how small, as it means to predict when they need to have something done, or if they could potentially have adverse outcomes. So going back to the 3D heart model, especially the physically printed one, that's a whole different world and a whole different space. That is still going to be in the realm of MRI and CT. I don't know if anyone's going to talk about that in the conference, but we need those modalities to create those really nice 3D printed models that I'm sure you've seen in general. Venture has a different role.
A lot of sense. And we'll just take this last question and then we'll kind of move on. Thank you so much, Dr. Soriano, for your time this morning. Are you typically using this to check how people are doing post-operatively, or is this more of a, outpatient annual visit implementation?
Yeah.
Maybe both.
No, it's a great question. It's really more on like an annual outpatient or ambulatory visit. There are definitely going to be use cases for patients that are in the hospital or inpatient. For post-op, the need for quantification is actually less of a priority. You can imagine for anybody that recently had surgery or had a procedure, the real goal is making sure they're comfortable, that they're recovering well from the actual procedure itself. And in that whole space, the quantification and the precision that VenturePoint offers, or even MRI that I've talked about, like those are things that are not needed or not necessary for the post-op recovery. Fortunately, I have to say that too, because they're definitely different priorities when they're getting better.
Well, again, thank you so much for your time. This was a really exciting presentation. We had such wonderful engagement and questions from the audience. So thank you. Thank you all. If there were any questions we didn't get to, Dr. Soriano, we'd love to send those your way and maybe get some answers, written answers, and we'll share those.
Yeah. Absolutely. Happy to do so.
Fabulous. Well, thank you. So as Dr. Soriano mentioned as well, we will be sharing a video about using VenturePoint technology for an actual patient and her going through her experience. So please stick around towards the end of the day today when we will be sharing that. We are now going to transition to our next topic, which is in the section of community education, where we're going to hear from brothers Rick and Mark Puder as they share their experience growing up as siblings navigating one brother's congenital heart condition. Rick Puder worked for over 30 years in customer experience and is known for his strong advocacy of blending customer feedback with storytelling techniques. He's been a big advocate in the CHD space. He spends a lot of his time working and serving with the community as a peer-to-peer mentor, and he's currently a board member of Ollie Hinkle Heart Foundation. And Dr. Mark Puder is an attending surgeon, professor of surgery, and principal investigator at the vascular biology program at Harvard Medical School, Boston Children's Hospital. He's a leading expert in the field of fatty acid metabolism as it relates to hepatic disease in children. So thank you, Rick and Mark. We're so appreciative of you being here to share more about your lives and experiences.
Thank you for having us.
Thank you. Glad to be here.
Fabulous. So I'm going to share some photos that I know you all shared with me beforehand, so that as we're chatting, if you guys want to reference to anything, you can do that.
Right.
So I want to jump in with you first, Rick. I know that it was really important for you to invite Mark to do this session with you. And I want you to maybe tell us, why do you feel like the subject of sibling relationships is really important to you, Rick? And then maybe Mark, you can share your kind of perspective as well.
Great. Thank you very much, Sydney. That's a great question, actually. I'm glad we started out with that. The relationships between those of us with heart conditions and our siblings is something that Mark and I have become very passionate about over the years. And really it started out when we were adults, because as adults, we started sharing our experiences, what my experience was like, what my perspective was growing up with a heart condition. And then he would share his experiences, what it was like to be my brother growing up through this, through the years. And so, when he started sharing his experiences with me, honestly, he said some things I just really didn't expect. So first of all, let me set this up. Mark is just 16 months younger than I am. So he's been through this entire journey with me, from at my side through doctor's appointments, surgeries, casts. He was always with me. And so while I was focusing on things like surgeries and casts and doctor's appointments and can I do sports? If so, what sports can I do? And I was focusing on those things. Him and my brother had a whole different set of challenges. And one challenge was just this constant fear that I wouldn't be around, that I may not survive. So this fear, lifelong fear of possibly losing one's brother, set very heavy with him. And then we also, as we were growing up, he experienced things like watching my parents grieve and watching them cry sometimes. And while he was in the hospital with me, he would see other parents crying when their children were having their surgeries and going through these events. So I realized just what a profound impact it had on my brothers. So when we started having these conversations, it was very healing for us to be able to share our experiences. And we also learned just how universal this was, because Mark and I have shared our stories multiple times in the past. I've shared our stories on my own a few times, and without exception, people come up to us, whether it's a patient with a heart condition or their family members come up to us and say, "Oh my gosh, I'm glad you shared your story with us. Let me tell you what happened to me. Let me tell you how I reacted when my brother and sister had surgery, or how my brother and sister reacted when I had my surgery." So it really created a whole healing process for people just by opening up the opportunity to share their stories.
Thanks for sharing, Rick.
So,
What are
well, I have to agree. I have to just agree with what Rick had to say. It did have a profound effect on us as brothers. You know, even to this day, for the last over 60 years, I still go to Rick's appointments. So he comes to Boston Children's, and I go to his appointments still. So when he comes to town, I'm on staff there, so I can move around pretty easily. Uh, it's, it had a profound effect on us because we didn't know whether Rick was going to survive or not. But I also want to say that it's important about siblings, but it's also very important about the parents, the primary caregivers, the aunts, the uncles, the grandparents, close friends, and other relatives that are also incredibly impacted by the fear of what goes on when someone has congenital heart disease.
Yeah, it's a great point. It's the whole family is in it together, and everyone is impacted and experiences that differently. Mark, could you tell us if you feel like Rick's CHD diagnosis and kind of surgeries experiences, did that influence you going into medicine? And did it influence other decisions you had in life as a child, young adulthood, kind of later adulthood? What do you think?
Yeah, well, as far back as I can remember, I've always wanted to be a physician. But when we first started this journey, at least I started the journey with Rick, I was only 2 years old when Rick had his operation. So my brothers are older, much older than me, but the physicians thought I wouldn't. As a 2 year old, they let me go in with my mother, but I have a very good memory of watching Rick with tubes coming out everywhere and seeing all that. So it influenced me strongly. And at that time, my parents were crying and very worried about his survival. And so I think it had a huge effect on my career decision to be a surgeon, to be a physician. As I was as I was worried about Rick, uh, I was concerned that the physician would mess up in the operating room and then lose Rick. I spent a lot of time on the wards with the patients. A lot of the parents were very upset. And so I became a physician, but also a scientist to try to figure ways to make things better for families and patients. And in fact, when people ask me why I spend so much time doing it, I just simply say, I don't like seeing others cry because I remember that so much with my own mother. So that's what it is. As far as decisions in life, that's the main decision I think it had an effect on me and how I deal with patients. And in fact, since the sibling is often left out, when I go see patients, if the sibling's in the room, I always talk to them first and ask them what they're doing, how old they are, before I get to the patient, so that they feel like they're not being left out of the situation.
That's such a great point. Like addressing them as people too, right? Like they're also part of the family. They're part of this journey and experience, even if they're not the ones actively undergoing the procedure. they're still, equally impacted, but in different ways. So I think that's a great point. I guess maybe a question for both of you. I know, Rick, you're a little bit older, and you guys have two older brothers as well. How do you feel like they were impacted? Were their life trajectories changed by your experience, or what have they kind of shared with you guys?
Yeah, that's a good question. I have two older brothers, so a little background. There's four boys in my family. We have two older brothers. There's me, and then there's Mark. So I'm number three. Mark's number four, as my parents used to refer to us as. And so my older brother, our oldest brother, is about 7 years older than I am, and he remembers very clearly what life was like before I was born in our household, and what life was like after I was born in the household. And so when I was asking him, when Mark and I were sharing our experiences, I asked my brothers the same kind of questions. And my oldest brother said, well, when you were born, we knew you were sick. We didn't know what was wrong. We knew you were very sick because mom and dad were spending all their time in the hospital. And so what I remember the most, he said, was how the energy in our home changed. It went from probably a normal family environment, but after you were born and you were in the hospital so much, the energy became very, very sad, very fear-based. So my younger years was living in that environment, knowing what it was like before and realize what a difference it was. And he said that had a very big impact on me. My second oldest brother, he's 4 years older than I am. And Roy was impacted in a way where he became my protector. He was always going to protect me. He's willing to fight anybody, anytime, to protect me. Even when a fight wasn't necessary, he was ready to fight. And so he was there for me at all times. And then even when when he was a teenager, so when he was 12 to 14 years old and I was 8 to 10 years old, when you're a preteen or a teen, the last thing you want to do is have your little brother hanging around with you. Well, not Roy. He brought me everywhere. He brought me with all of his friends. He was a great musician, so he had a rock band in junior high and a rock band in high school, and he made sure me, his little brother, got to have a part of that too. So he handed me a guitar, taught me some strumming patterns. I was a horrible musician, but he taught me just some strumming patterns so that I could participate in his rock bands. So to this day, Roy is still my protector.
That's awesome. I think that the kind of flip side of that, and Rick, I know we've talked about this outside of this space, and I feel a similar way, that sometimes the CHD experience feels more difficult for those around you than for you going through it, because you're like, this is just my life, this is what I'm experiencing, and sometimes those around you are having a harder time. Can you maybe tell me more about that from your perspective, and then Mark, kind of weigh in, tell us how you think.
Yeah, that's a really good point. I've said this lots of times, and I feel it very strongly that in many ways my heart condition had a more profound impact and more difficult impact on my brothers and from my parents. So when Mark and I started having these conversations, it was when we really hit in earnest when our mother was diagnosed with cancer. So she was diagnosed with cancer, and there was a 2-year period before she passed away from the cancer. So when that happened, there was a big shift in my life. I shifted from being the care receiver to the caregiver. And all of a sudden, I started feeling all those pains of fear that she wouldn't survive, feeling bad because she had to go through all this pain with all the treatments she had to go through. So I felt it very profoundly. And I remember when Mark and I both took care of her in every way we could. And I remember one time I was in her apartment, and she said to me, "Rick, you don't have to do all that for me. I can do this myself." And I said, "Mom, when I was growing up with my heart condition, you were always there to take care of me. Now it's my turn to take care of you." And so she started tearing up. She came to me and just gave me this huge hug. And then as we were having these conversations, I was telling her about Mark and I talking about the effect it had on him with me and my heart condition. And she looked at me and she says, "Rick, you would not believe the impact it had on Mark." She said, I don't know if I ever told you this story, But she said when you had your second surgery at 13 years old and Mark was 11 years old, it was the night before your surgery, and none of us could sleep. And Mark came up to me and very seriously said, "Mom, Rick and I look an awful lot alike. I bet I could take his place and nobody would know." So she said, Mark was he wanted to take your pain away. He was willing to put his life on the line so that you wouldn't have to. When she told me that, it just really hit me, the incredible effect it has on our family members.
Well, now that we're all sobbing, right? Yeah, I think that's what an amazing story. I'm sure a lot of siblings feel like that. I guess, Mark, what would you say? Do you feel like it was harder for you? Do you still feel like you wish you could take that for Rick?
Yeah, well, there were two reasons. One, that Rick was also worried, and my mother was crying, and you know, the family had always been focused on Rick's health, and so I thought the biggest disruption would be losing Rick. It felt like my understanding was someone had to be lost potentially, and so that's how it was. And so I was very fearful of losing Rick, and so even when they rolled him, to the operating room, I followed, and I watched as the elevator closed because I wanted to be the last one to see him, and because they gave us pretty poor prognosis. Turned out he did quite well, obviously, but yeah, it had a big, profound effect on all of us.
If you guys could talk to yourselves when you were kids, or if you could give advice to other parents whose children who have a heart condition, who have siblings, like, what would you say to them? What would you say to yourself? What advice or recommendations would you give, kind of looking back?
Yeah, I've got a couple of recommendations, and it's for us, for the heart condition, it's for our siblings, it's for our parents. And so when my mother, first of all, let you know before I go into the recommendations, Mark and I were very fortunate. We had the very best mother anybody could ever ask for. Caring, loving, supportive. She did everything she knew to do. She did the best she could, and she's just incredible. So when we were having these conversations with her about growing up with this, and we're sharing our experiences, she would often say, "You know what, Rick? If I would have known that, I probably would have done this differently, whatever this was." And so no blame, no finger pointing. It was just sort of a discovery process, a learning process. And it was very enlightening. So my couple of recommendations would actually be my mother's recommendations as well. And one is, make sure you share the focus, the attention with everybody, with all the kids. Even when it comes to presents, when I had my surgeries, I got gifts from a lot of people, my parents and friends, but Mark didn't get anything. So recognize that they're there, they're watching, they're afraid too. So include them in those processes. The second thing that I would suggest, and that we would suggest, is be very aware, everybody in the family, be very aware how it's affecting you, your siblings, your children, all of us, because it has a profound effect on everybody. Even when the other siblings aren't showing it, and often they don't, because they don't want to be fairly stoic so they don't upset their parents more than they already are. It's happening. It really is there. Remember, it's very universal. So seek help, get guidance. That's one thing I love about Ollie Hinkle Heart Foundation. When I first got engaged with the Ollie Hinkle Heart Foundation, one of the things that got me excited, they have their Ollie's branch with therapists across the country, and they help parents, they help the patient with a heart condition. But very importantly, I saw what got me super excited. They also help the siblings. So seek out help. Today there's more help than there ever was in the past.
Yeah, my advice. Sure. My advice would be similar to Rick's, but also what I recommend for parents and family members that have a sick member is that the parents actually, or the caregivers, go and even though the patient in the hospital, go and have date night to maintain their relationships. But also involving the siblings, it's important. A lot of times the father or the mother or both will take the sibling just out and give them a lot of attention, whether they go to an amusement park or out to dinner, to make them the center. The other thing is that when the parents do look after the other child, that even though sometimes it's subconscious, they need to make sure that at Christmas time or holidays or birthdays, that they also make sure that they do look after the sibling and make sure they do receive the presents. And lastly, I recommend now, times are different now, a lot of departments have support groups, but also psychologists, social workers who actually help the sibling work their way through these difficult times. So those are the 3 recommendations I have.
Yeah, that's great. I think you both touched on this idea of, jealousy can pop up, or, resentment. Do you feel like that was a comment that came up in our chat as well? Do you feel like you guys navigated that in your childhood as you were growing up?
You want to take that one more?
Well, as a child, you do feel, I wouldn't say necessarily jealous, but you can definitely sense preferential treatment. But it hasn't had any negative effect on our relationship. I think we're the 2 closest brothers, and we still, like I said, we do things together. We speak every day to every other day to each other, and have been doing that for 6 decades. So I don't think it has had a negative effect. In fact, I think it improved our bond over time, myself.
Yeah, that's really wonderful. I think kind of on the flip side of that, there's a lot of grief and guilt that goes along with having a CHD and navigating that as a family, and especially having other children. So how do you guys feel like, this was also a question from our community, how do you handle, or did you handle, the grief and guilt of the pain and sacrifice that your family went through? Rick, how did you maybe hold on to that yourself as the individual going through the experience, and Mark, maybe from the perspective as a family member?
Yeah, from my perspective, I was so focused on getting better and having my surgeries and all that. Honestly, I wasn't that aware of the fear and guilt they had until we really started having these conversations. And that's why I encourage these conversations. It was what's helped us the most, what helped me with my mother and helped me with all 3 of my brothers, and Mark in particular, is it helps just to be open and share it. No blaming. No, when Mark was saying, I felt this way when you were sick, you got the gifts and I didn't. There was no, or my mom, what's happened. There was no finger pointing, no blame. It's like, have a conversation just to discover how each other felt and appreciate that. So I had a whole new level of appreciation of what everybody went through, and then being able to openly having these conversations at that point on was extremely healing for me, and I believe for them too.
Yeah, I think there was grief, but there wasn't a lot of guilt. I don't think I was born into this, and this is the way the life was. I had a brother who was sick, and I was born into this family. So I don't think that it was part of a guilt type thing in there. It's just, we looked after Rick, and, though I was the younger brother, we protected Rick, and that's what we did. And so I don't really feel like that created much in the way of any hostilities. I think I learned a lot from worrying about Rick. Is, for example, when a family is really worried about their child and we're going to do a big operation, I do tell them the story about how I worried, and I understand, and I'll do everything I can. And in fact, that's why I tell the residents and fellows who operate with me, let's think of everything that can go wrong and let's not let it happen. And so it's been a it's been a real blessing in a way to where I can actually explain to families and take away a bit of anxiety.
Yeah, just one more point too. Your good point about the guilt is that it was more of appreciating understanding, and also Mark said him and I talk all of the time, and when Mark and I talk with my other brothers too. So the four of us, and perhaps these experiences together over the years made a difference. We all talk regularly. I talk to Mark probably more frequently, but Roy and I talk at least once every week or two. Same thing with my oldest brother. So we really formed some really strong bonds and open communication about these.
Yeah, I think that's so important. And I know a lot of parents are the ones that are so worried about feeling guilty, right? You have to leave a child at home to go tend to your sick kid who's in the hospital. And so, what do you think was helpful for your parents, or what would you say to parents now who are like, what do I do? How do I help and navigate that feeling?
Rick?
Right, Mark?
Go ahead, Rick.
Okay. So what I would say is my recommendation is one of the recommendations I gave earlier is seek out help. There are other parents. It's about today. When I had my first surgery, that was in 1962, and they had the wards. It was impersonal. It was very difficult for everybody. The visiting hours when I was in the hospital was only 2 hours a day. So my parents only got to see me for 2 hours a day while I was going through major cardiac surgery. For 3 weeks, I was in the hospital. So seek out help. This out there, whether it's through Ollie's branch or through what's available through the hospitals. I told you Mark and I had given this talk before. We did a panel just like this at Boston Children's for the staff, for them to hear about it so they can see what it's like, so they can understand what parents and siblings are going through. So the help is there. Don't hesitate. Don't think about it as counseling or guidance through this process.
What he said.
Ditto. Okay, well, we'll just do one more question. I know we'd love to chat with you guys all day. We love hearing from you and chatting with you. But I know, Mark, you brought this up a little bit, and Rick, we've talked about this in the past, but thinking about patient-centered care and really family-centered care, like what is that? What does that mean? How are the big moments that are happening important, and how are the little moments that are happening? How are those important? Rick, I'll start with you and then would love to hear from us.
That's a really good question, and that's something I actually talk about a lot when I talk to caregivers, hospital staff, families. It's oftentimes the little acts of kindness that make all the difference that people remember. It doesn't have to be this really big, elaborate, strategic plan. It's what we do every day. So let me give you an example. When I had my first surgery, I was 4 years old, and I remember as if it were yesterday. And if in the hospital was a ward, and if you look at the picture there, the top right picture is a picture of a pediatric ward. Imagine 20 of those cribs just lined up all the way down there, and it's very impersonal ward. And so it was difficult, and I was alone 22 hours a day. So and then I was toward the far end of the ward, and on the wall above me, up on the mound of the wall, was a small black and white TV that they would, and every morning when I would wake up, I would watch cartoons. And I'd be sitting there by myself watching cartoons. But every morning there was this young orderly, this young man would be sweeping the floors of the ward every morning. And about the second or third morning that I was there, he comes by my crib and he looks at me and he looks up at the TV and he says, "So what are you doing?" And I said, "Well, I'm watching my cartoons." He goes, "What cartoon are you watching?" And I told him, "I like that cartoon. It's my favorite cartoon." So he said, "Can I sit here with you and watch it with you?" And I said, "Yeah, you can. I would love that." So every morning he would stop, come by my crib, and watch for about 15 minutes, watch my favorite cartoon with me. Here's my point. That was 62 years ago. And I can't tell that story without tearing up today. It had that much of an emotional impact on me. So it's just a small act of just spending some time. So sometimes I'll tell parents, just sit down on the couch with your kids, watch their favorite TV show, and just enjoy the moment with them. I said it'll change your life, and believe me, I know it'll change their lives too.
Amazing.
Well, my suggestion is more towards the caregivers. Uh, that is, uh, being understanding the importance of the family and the anxiety that patients have, and ways to diffuse it. Not only provide the support groups, but also develop support groups for families. And the other thing is being available and seeing your patients every day, which just even a few minutes makes it so much easier for the family, because the anxiety of the parents gets transmitted to the child, and the child has anxiety also. So I encourage caregivers to, see their patients every day, listen to their concerns. A lot of times when parents are angry or upset, it comes across as anger, but that's easily diffused by supporting the entire family and the patient.
Such a meaningful message. It's really everyone involved in the care, from the people taking out the trash to the surgeon to the nursing staff, and really everybody involved in taking care of not just the patient but the family, and providing resources and support. So thank you both so much for your time today, for sharing your story. I know we would love to continue chatting with you for the rest of the afternoon, but we really appreciate it. I think there were maybe a few questions that we didn't have time to get to, so we'll follow up with you guys, and maybe you can share out some thoughts with our community afterward.
Absolutely. Thank you very much. Thank you.
Thank you for having.
Yeah. Okay. We are going to take a very short break. We'll just give about 3 minutes so that we can get prepped for our next session, and we will see you in a few. Thank you.
Welcome back from break, everybody. As Rick and Mark touched on during their session, heart children, their caregivers, and adults with CHD are at an increased risk for mental health issues. Excuse me. These experiences have significant and lasting effects on the whole family. We are thrilled now to welcome Dr. Laura Orm, who is a licensed psychologist. She has a wealth of experience and has been working with the Ollie Hinkle Heart Foundation as an Ollie's branch partner therapist since May of 2022. Today, Dr. Orm will be talking about fear, isolation, and loneliness, how to disrupt the cognitive cycle. We know many heart parents and their families, as we just heard, grapple with feelings of isolation, lack of belonging, and loneliness. Often families find themselves caught in a cycle of these feelings and struggle to get out. Dr. Orm will be providing insight into why this may be for many heart families, how this shows up, and how to disrupt this cognitive cycle within yourself and for the people you care about. Welcome, Laura.
Thank you. It's good to be here today. Thank you for having me. I really appreciated hearing a little bit about Mark and Rick's story before I came on. Thank you for sharing with us. I'm adjusting my screen here. So yes, I am a licensed psychologist. I have been working with clients referred by Ollie's branch for over 2 years now. I'm officed in Houston, Texas, and I work with clients in person here, and I'm able to work with clients via telehealth in about 42 US states. In my practice, I currently work primarily with adults, some amazing adult heart warriors, and mostly parents of children with CHD. I also work with clients going through other various life adjustments, relationship problems, and coping with other chronic medical conditions. When I spoke with the Ollie Hinkle Heart Foundation team earlier this year, I mentioned some of the trends I had noticed with my heart families, particularly related to this cycle of isolation, loneliness, and fear. So I'm thrilled to be here today to speak with you about this topic. And I hope to impart some hope and equip you with a few actionable steps you can take to find if you find yourself in this cycle. There is no question that those diagnosed with heart conditions and their caregivers and family members encounter a tremendous amount of adversity. And for ease today, I will refer to this group as heart families. Most heart families have experienced or witnessed life-threatening medical events. The stressors that this community faces are ongoing, chronic, and repetitive. And I hear the stories of caregivers that show up, closely monitor a heart warrior's care again and again. And in this community, a person diagnosed with a heart condition is referred to as a heart warrior, and warriors you are. And I see the parents, siblings, family members, caregivers of these individuals as warriors too. You are all warriors for your heart warriors, for yourselves and your families. You are truly remarkable in your care and how you continue to show up in the most difficult of situations. I also recognize that heart families don't always feel like warriors because warriors feel tired too. Over time, the severe and ongoing stress adds up, and it's not uncommon for heart families to feel as though they cannot take any more. It takes its toll. What's amazing about this community is that in the long term, most families adapt successfully to living with CHD. You're incredibly resilient, and about 40% of parents report a need for psychosocial interventions to help improve coping. As you can see from this slide representing some of the ongoing medical related stressors of living with CHD. When stressors are numerous, whether they be medical, financial, relationship problems, when they're chronic, repetitive, and ongoing, they do have a cumulative effect. It really takes a toll on the body because the body is in a constant stress response state. And in these situations, coping becomes more challenging and the likelihood for needing support to address mental health difficulties increases. So it just makes sense because even warriors are human and everyone has limits. What is especially difficult is that the challenges of living with CHD can require a significant amount of time and attention, and there is time devoted to navigating complex medical procedures, long hospital stays, coordinating care, and the emotional and financial strain related to caring for a chronic health condition. Families may struggle to access the support that they need, and families by default may begin limiting their interaction in the community. If they are concerned about respiratory illnesses, for example, or can't find an adequate caregiver, and then this contributes to isolation and isolation from connections that they may have previously leaned on in the past. So loneliness for heart families is this profound sense of isolation and disconnection that can happen when caring for CHD. It's the feeling of being alone, even when surrounded by others. The complexities of managing a child's medical needs can create a divide between heart families and those who have not experienced similar circumstances. Heart families feel misunderstood and under-supported, oftentimes unseen, while the rest of the world whirls by them at record pace. Even more, there's an experience of each condition being really unique. And this is true. This is what families with CHD hear from their medical teams. You are unique. There's no case like yours, or if so, very few. So patients with CHD rarely have the same story. Even when heart conditions are similar, families have different experiences with recovery, different outcomes, or other co-occurring disorders, ranging from genetic disorders, autism, mental health difficulties, or different trajectories for growth, or ranging resources for coping with all of the stressors. So no two stories are the same. I notice as I work with families that most feel incredibly alone, and alone is big. Many feel as though no one can understand them, and so they remain alone. It's true that new supports for heart families are needed, and they are growing. And it's true that the sheer amount of stressors that heart families are going through present a barrier to utilizing the resources that are available. I just want you to stop, take a minute, and to think about your own experience. Think about what it's like when you are told this narrative that you are very unique. Does it make it more or less likely that you will trust your support network? Does it make it more or less likely for you to share your experience with others? Now I want you to consider this. While heart families are each incredibly unique in their stories, they are not unique necessarily in their experience of loneliness. In 2023, there was a Surgeon General advisory published on what was called an epidemic of isolation and loneliness in the United States, identifying it as a public health crisis. With a rise in social media use, increase virtual over real life connections, Americans are more fragmented and distracted from everyday life than they've ever been. There are increasing pings, distractions, and demands coming through multiple electronic devices. There are also increasing financial demands, along with isolation resulting from the COVID health crisis. Increasingly, people in general are living alone and in single family units far away from extended family that may otherwise support them. Overall, Americans are spending less time in community engagement. So it's not surprising that Americans are isolated and lonelier than ever. So while heart families have their unique struggles, their battle for connection and support is also challenged now by this broader experience of isolation in society as a whole. We're going to put a bookmark here because we're going to revisit this in a few minutes. There is a significant correlation between post-traumatic stress disorder and loneliness. Loneliness can be either social or emotional, or both. Social loneliness happens when you're limited in your actual social interactions. There's not a lot of people around you. Emotional loneliness happens when you are surrounded by a group of people, but you still feel alone. It's the experience of feeling lost or alone in a crowd. the relationship between trauma symptoms and loneliness is a reciprocal one, meaning that the more lonely you feel, especially if you feel emotionally alone in a crowd, the more likely you are to experience a trauma response following an adverse event or a life-threatening situation. Even more, some of the symptoms of PTSD and acute stress disorder include responses that are inherently protective, avoidant, and isolating. They cause people to pull back, further continuing the cycle of loneliness and trauma. Let's take a look. So, following either experiencing or witnessing a life-threatening event, it's possible to develop acute stress disorder or a post-traumatic reaction that can severely disrupt daily functioning. These symptoms include intrusive, unwanted, and distressing thoughts about what has happened, deliberate efforts to avoid places, thoughts about places, activities, appointments, or people that may remind them of the event. They may have persistent and distorted negative beliefs about themselves, the others, or the world. And we're going to talk more about this particular aspect in a minute. And have a reduced ability to experience positive emotions, and an increased irritability, hypervigilance, an exaggerated startle response, or difficulty sleeping and concentrating. And while the mental health symptoms that I just mentioned may be noticed first, it is also possible that mental health symptoms are not recognized first. Instead, it's possible that the signs of chronic stress and trauma become evident in the body. Living with in a chronically stressed and a hypervigilant state can take a toll on the body. As you see on this slide, this could show up as chronic pain, digestive problems, or impaired immune functioning, difficulty fighting off infections and disease, or difficulty with memory or concentration. So recognizing the symptoms and potential signs of a stress or trauma response is really important to accessing suitable treatment and managing symptoms. You can see how whether you're dealing with physical or mental health symptoms related to chronic stress and trauma, they can have the potential to reinforce patterns of isolation and loneliness. Let's look specifically at the cognitive symptoms of trauma that include persistent, distorted, and negative beliefs about oneself, others, and the world. And I want to look with you at ways these beliefs tend to manifest themselves, especially for heart families. So note that these are simply examples and not tended to be exhaustive representations of experiences. So bear with me if they don't exactly fit your situation. There can be concerns and thoughts regarding safety. This includes beliefs about the world being unsafe and unpredictable, leading to hypervigilance and avoidance of activities that may trigger trauma reminders. For heart families who have experienced unexpected loss or unexpected emergent medical events, this could result in avoidance of activities that remind them of the event. It can also lead to avoidance of activities that, in their view, could potentially put their heart warrior at risk in any way. There becomes a tendency to bubble wrap them to protect them from the bumps and bruises of everyday life. This can prevent the heart warrior from having opportunity to develop the resilience and coping skills that naturally can occur from daily risks. It can also lead to isolation through avoidance of activities and community engagement. The other theme that may emerge are issues with trust. This includes difficulties trusting others, including healthcare providers, due to perceived betrayal or lack of support during a traumatic event. It can also include trust of self in making medical decisions. I see this a lot. This can create a barrier in utilizing resources that may be present in navigating complex medical care. There are issues of power and control, feelings of powerlessness and lack of control over your health or well-being, especially when managing a heart condition. Issues related to self-esteem, often related to a perceived burden that their trauma or a heart condition places an undue burden on those around them. There can be issues related to intimacy, really challenges in forming and maintaining close relationships, the theme of today, due to fear of vulnerability, concerns of impact of their trauma on their loved ones. It can also, or their heart condition on loved ones. It may also manifest in thoughts related to feeling particularly unique, so that no one understands them. So here you can see a bit of a word salad, the type of emotional experiences, including depression, anxiety, distressing thoughts about being unique, alone, unsafe, who do I trust, and various behaviors, including withdrawal. This can be very confusing for heart families because they begin thinking or feeling different than they may have in the past. I think that this graphic represents really how confusing the experience can feel, because there has been a very real lived experience of isolation and hardship, and these thoughts begin swirling with a potential of reinforcing themselves. So let's review the cognitive cycle. As I mentioned first, there is some type of adverse life-threatening event or a repeated unwanted chronic stressor, and this leads to increased sensitivity to perceived threats and difficulty processing information and experiences objectively. Then we have isolation, a very common experience for heart families. Prolonged isolation and feelings of loneliness can reinforce negative cognitive patterns, amplify fears, and perpetuate a cycle of withdrawal, disconnection, and avoidance. Then further reinforcing the cycle of isolation and loneliness. The cycle then repeats itself. Without practical support needed, heart families have more difficulty coping with any future events, and the cycle continues. But it doesn't have to. By better understanding the complex relationship between trauma, isolation, and cognitive patterns, we can develop more effective strategies to break the cycle and foster resilience and connection. But how? Mental health therapy can be very effective in addressing this cycle. There is no one-size-fits-all treatment approach, and different treatments may be helpful for you depending on your needs. I've listed some effective forms of trauma therapy for you on this slide. A lot of people like EMDR to address trauma, but cognitive processing therapy, prolonged exposure, or advanced spiritual dynamic processing, an approach I often use, are also good options. Cognitive behavioral therapy can also be helpful in addressing these cycles, and psychodynamic therapies are also very helpful for addressing relationship problems and maladaptive coping patterns. There's also a skills training program called dialectical behavioral therapy that can be very helpful for coping with trauma and prolonged stress. DBT may be taught by an individual therapist, but is often offered in group settings, which makes it a particularly affordable and accessible option. It teaches skills in emotion regulation, distress tolerance, mindfulness, and interpersonal effectiveness, which can be particularly helpful for heart families who often navigate complex relationships with family members and healthcare providers. Also, Ollie's Branch is a wonderful resource that you have and can be a great place to get started. And I believe that Dr. Alexander will be with you talking about mental health resources this weekend, and will provide you some guidance in finding them. So the goal is that treatment will help you to address barriers that otherwise prevent you from connection and support, so that you can build a supportive network, engage in activities that foster a sense of belongingness and purpose. So one step, seek mental health support. Another step to begin taking is to find ways to overcome isolation through connection. Again, it's not just heart families dealing with isolation. It is America in general. Our society as a whole has become more fragmented. So it does take some effort to begin cultivating a diverse support system, family, friends, mental health providers, and begin engaging in regular social activities. Find something you love, do it regularly. and through this, you can build connections, prioritize quality over quantity, look for relationships you may be able to go deeper in, and seek out an online community. But this can be a great resource for families who may otherwise be isolated. Being able to connect online is a great resource. I do encourage you, though, to make it as synchronous, meaning face-to-face at the same time interactions online. So making it as real life as possible when you're using online resources. And then challenging ourselves in this online world to find ways to have real face-to-face connections also. And practice being vulnerable and authentic with others. It's a risk, but it's well worth it. There are barriers to building this type of connection, and one of the barriers that heart families often bring up is related to the uniqueness of their particular situation. As I mentioned earlier, each heart warrior and heart family's path is incredibly unique. Heart warriors or families may have difficulty finding groups where they feel like they fit in. I even hear how heart families feel isolated from other heart families because each story feels so different. And this is one of those situations that is a both and type situation. That yes, your situations are so different and there is much you have in common. And I know that you know this, but I want to articulate it for you today. Just some of the commonalities that you have, such as this experience of confusion or uniqueness about CHD, a significant financial burden that's present for families, that the entire family is impacted by the stressors, that stressors are ongoing and chronic. There are hardships that encountered when you go through treatment. And another shared experience is that what might seem like a normal transition or event by some families or other children or individuals can feel more complicated for you. So these are just a few of the shared experiences that you may have, very significant experiences that you share in common. But I want to encourage you to not shy away from the differences. One, because they're unavoidable. You will not find someone else just like you, but that does not mean that you cannot have meaningful support. Build the skills of learning to find common ground in your diverse communities. This may be with other heart families. It may also be in other groups or communities. So find common ground and interests, practice mutual respect, which requires listening and learning about differences. Practice curiosity about things that are different or that you don't understand, and practice empathy with each other. Wherever you find yourself, practice leaning into the community that you have available to you rather than waiting for the perfect community or group to come along. Practice holding your very unique story while making space for someone else's unique story. Share them with one another and hold each other in mind in both the uniqueness and commonalities that you share. Lean in, and you may be surprised the type of support that can develop. This does not happen overnight. In fact, it can take time and significant investment to build community, but with time, you may see an imperfect, yet good enough, meaningful, and substantial support system develop, both that you receive from, but that you also contribute to. There are barriers to building community, but there are things you can do to support your mental health and to build your capacity for resilience and in the future. And building connection is a significant part of building and cultivating that resilience. As you practice self-care in other ways, the very important ways like taking care of your body, exercising, eating well, showering, meeting your basic everyday needs. As you build your coping and emotion regulation skills, seek mental and mental health and medical care that's needed and connect with others, you're going to equip yourself to face what lies ahead. So when I speak of these things, I'm often concerned that it can oversimplify the experience of families that I work with. So I want to reiterate that while this cycle and how to address it is laid out in a rather simplistic way, I realize it really is a battle. The barriers are real, and I know how frustrated heart families can feel as they go through this process. But that is all for my presentation, and hopefully that leaves a little time for some questions.
Thank you so much. I know our video is popping back up here. Thank you so much. I think there were so many great pearls of wisdom in what you just shared with us. We do have a couple of questions too that we would like to pose. So there was a question and then some additional conversation in the chat about connection with an adult congenital heart community online. Do you have, I know we've talked about the ACHA, I know some other folks offered some other opportunities on the chat, but do you have any specific connections to the adult online congenital heart community that you could share with the group attending today?
I don't, but I think that would be a great question for Dr. Alexander that's going to be talking about resources. I think it's very community specific, and I think that that's a problem that a lot of families begin looking for, or individuals, adults begin experiencing, is they have problems identifying these groups. And so definitely looking for, and hopefully Dr. Alexander will be able to identify some specific ones today or this weekend. But that's why I encourage the people I work with to really lean into the communities that they have. Because oftentimes connecting with very specific groups can feel more challenging.
Thank you.
It's just hard to identify.
Absolutely. And we certainly will take that and put the pin in that for Dr. Alexander tomorrow as well. There was another question that came through about the process for engaging with parents from a therapy standpoint. So the question is more of, how do you kind of start that conversation with a parent? Do you just dive right in to the trauma of the diagnosis, the birth, surgeries, or is it more of an unpeeling process where you get to know the parents, the family first? And then I guess the other piece of that question is, if there is an unpeeling process, how do you know when it's the right time to then kind of dive into the trauma related pieces?
Everyone is different, and everyone is at a different stage of readiness. I work with some clients who come in and they are ready to dive in. They know that they're ready. They are seeing me for that purpose, and they dive in and they work through rather well. I work with other individuals who aren't quite ready, but that therapy is for that too. Therapy sometimes requires building a relationship, really facilitating the safety that's needed to address trauma. And so it can take longer for some people. And I think that a good mental health clinician is going to really look at the needs of each person and where they are, and will not push a person past their readiness. They're going to equip them with skills that they might need, resources they might need to address trauma if necessary before getting to it.
Okay, thank you so much. I know there may be some additional questions that pop up, and if so, we would love to be able to send those to you, Dr. Oram, and see if we can get some responses to share back with the group.
Great, thank you.
Thank you so much. Mental health, as we've heard several times today, is such an important aspect of the heart journey for so many families. And oftentimes children born with CHDs require frequent open heart surgeries, and sometimes that can prevent them from living their lives to the fullest. Our next speaker is going to take us back to some exciting technology, telling us more about polyvascular. Polyvascular provides the only non-surgical pulmonary valve and delivery system suitable for children as young as 2 years old. Their minimally invasive valve reduces the need for open heart surgery and enables kids to enjoy a healthy, normal lifestyle. I am very happy to welcome Katie Bales, who is a heart mom. She's also the VP of Investor Relations at Polyvascular, and she is going to share more about this work and her experience getting involved in an industry space. A quick reminder about the Q&A box, if you have those questions while Katie is speaking. Welcome, Katie. I'll hand it off to you.
Hi, thank you, Laura. Hi, everyone. There we go. Wanted to say thank you, of course, for having me and allowing me this opportunity to talk about my journey kind of into the pediatric cardiology world. And it's been great to hear all the speakers before me, and I think we can all agree kind of to the valuable insight these talks are, and look forward to the rest of today and tomorrow. So, as Laura said, my name is Katie Bales, and I always like to start by saying that I'm a heart mom to my now 7-year-old son, JJ, but the reality is, and to any parents and caregivers on the call, you know that we wear lots of hats. So like Jen and Mark, who have started and grown this amazing foundation, a spark was lit in me when my son was born with a complex congenital heart defect. And I'm excited to share our journey here and kind of how it aligns with so many of the wonderful things that the Ollie Hinkle Foundation does. I know we have a few other families and patients and caregivers attending today, so I wanted to just quickly take a pause and inform you that I have a few potentially sensitive images in the next few slides. So if anyone wishes to, lower their browser or step away for about the next 6 minutes of my presentation. So my journey, or our journey, into the congenital heart world started at my 20-week ultrasound. My unborn child was diagnosed with moderate, really mild to moderate pulmonary valve stenosis. We were insured by the fetal cardiologist that his diagnosis, while of course was serious, was fairly mild, and few interventions would be needed when he was born. That news was hard to hear, but it felt like there was a plan and it could be managed. However, 2 weeks later, when we were at a follow-up appointment, we got a big wake-up call. That follow-up fetal echo, his diagnosis had drastically changed from that mild to moderate PVS to critical, and really was borderline atresia, and we were devastated. This was much more serious of a diagnosis with a path towards a single ventricle repair. So suddenly we were being counseled on kind of the need for multiple open heart surgeries and a lifetime of unknowns, with his care, right? So due to that acceleration of his valve disease over those 2 weeks, our home institution referred us to a few other centers in the US that were conducting fetal interventions to see if JJ would potentially be a candidate. This was kind of the point in my journey where my outlook on congenital heart care treatment really changed. I started to see drastic disparities in so many aspects of care in this space. And because we were offered this fetal intervention, I think the first disparity I really saw was in the lack of research and kind of understanding that surrounds some of these complex congenital heart defects. Excuse me. We were being offered this highly risky but potentially life-changing intervention for our son with almost no research to support it. We were asking questions that our medical team couldn't provide solid answers for. When we asked about the success rate of this type of intervention, the numbers were so small that it felt almost insignificant, that we would kind of be rolling the dice to see if this would work. Couldn't quite wrap my head around why we didn't know more and why so many people would respond to our questions and say, you don't need a fetal intervention. We're really good at these surgeries when your son is born. We have really worked at lowering our mortality rates. And I would have other doctors say to me, but if you look past the success rate of the surgery, there's other aspects of your child's life that will be different. And then we began to talk about things like mental health, the potential for neurodevelopmental delays, all of these kind of other layers, right, that are part of our kids' lives. And so we moved beyond that mortality rate of, the Glenn or the Fontan surgeries and into kind of what my child's life was going to look like. So all of a sudden we were in this position to make a decision on moving forward with this intervention with little research on one hand, and then being told that if we don't do something, that his quality of life could be significantly impaired. So the next kind of big disparity I saw through this process was the inequity of available resources. So my family and I were privileged enough to be able to fly to these different centers for referrals. We were privileged enough to have a reading level that allowed us to do our own research, and an education level that provided kind of a base understanding of what we were being told. We had the privilege of being treated in our native, our first language. We understood everything that was being told to us. We could grasp the severity in each discussion, and we could process our options in those moments. So this is something that I feel like can easily be, taken for granted, but it really highlights some of those major issues and treatment for this patient population. So ultimately, we did not do the fetal intervention, and JJ was born with PAIBS. So fast forward, he's had a pretty unique and kind of fairly unknown path through his life. He had 3 interventional cardiac caths, and then at 6 months, instead of performing his Glenn, which is pretty standard of care for his defect, we placed an occluder in his ASD to see if we could promote blood flow through his tricuspid valve, eventually help grow that right ventricle. This seemed to work, and year after year we would show up to the follow-ups, and while the right side of his heart was severely underdeveloped, still it seemed to actually be growing, and that intervention from 6 months old was holding, and JJ was living his life. We've been fortunate enough that he's had no significant neurodevelopmental delays. And, that was something that was such an unknown, right? Looking back at that 22-week fetal echo and making these decisions on that intervention. About a year ago, JJ went into kind of early stage liver failure due to that high pressure in the right side of his heart. The congestion to his liver was causing significant scarring, which we found during subsequent liver ultrasounds and eventually a liver biopsy. So earlier this year, we found ourselves in a similar position to where we were when I was 22 weeks pregnant, and the same position we were in when JJ was 6 months old, and we were trying to decide our treatment and what we were going to do. So we could proceed at this point, he's now 6, to do his Glenn or even his Fontan if we needed, or we could travel to another institution that was attempting to do a different and recreate the standard of care. So after a lot of research and talking to many specialists in the field, we once again decided to forego his Glenn and try a tricuspid valve repair and right atrium reduction to see if we could alleviate some of the liver congestion. So this brought up, again, a lot of unknowns. Would the repair work? Was his pulmonary valve, in good enough shape for this lifelong use? Should we replace it while they had him open? What were the options for valve repairs? And doing so, if we replace that valve, right, would subject him to lifelong replacement needs. So the disparities here in the pediatric medical technology really became like blaring to me, in this moment. So if I look kind of at those past 7 years, I can tell you so many different stories, but the one I want to talk about today is the need for that advancement in medical technology and research and innovation. I have seen, through JJ's life, how all components of innovation impact a family's life, a patient's life. I can scale it from small innovations to big innovations that make a drastic difference in our kids. I didn't know what this meant until I was living with it, right, in our day-to-day. So the picture you're seeing here is just one example of that small innovation and how impactful these things can be to families as a whole and to the child's health, the child's mental health, which of course we've been talking about a lot today. So the picture on the left is JJ at about 3 years old with his 24-hour Holter on. So you can see like the extensive, tape that would later bring tears and whelps as we try to remove it, and the wires that would get tangled and prevent him from doing his normal toddler activities, the wires that would make me stay up, and sleep next to him all night because I was worried he was going to get tangled in them, and the big box that he had to wear to preschool on his shorts, and the kids would ask him about it, and he was too young to, fully understand. So you compare that to the picture on the right with the new technology and the new wireless halters that we have now, just a small sticker, and it can hide under his shirt. And so when he shows up to school in 2nd grade, he doesn't have to carry that mental load with him. He doesn't have to stress about, what am I going to say to my friends if they ask? All of a sudden, he has the power to talk about his heart defect or not. So what could be deemed as a small innovation is drastic to our little kids and to our families. So this is what led me kind of into what I call my new passion for advancing, medical technology in pediatrics, and then of course specifically, in cardiology, because I can see how it extends beyond the capabilities of an individual device, and it really transcends to impact their day-to-day and impact their mental health. So how do we begin to kind of prevent these layers in every aspect within the CHD patient's life? So if we hold on to this idea of kind of innovation at any scale, right, can significantly impact the patient population, then we can talk about prevention on many different levels. Prevention, like little things like the headache, the annoyance, the mental load, right, of wearing that halter with all the wires. But we can also talk about larger scale prevention, like multiple open heart surgeries, which led me into my work with polyvascular. So a few years ago, JJ's interventional cardiologist approached me and said that he had been working with a team to develop the first ever polymer-based pulmonary transcatheter valve that was designed specifically for small children. So currently, if a child's born with a severe congenital heart defect and they need a valve replacement, the options are limited. Their options are surgical heart valves, and these valves can fail very rapidly, sometimes even, within a few months. They can't grow with the child. So we get into the space where these kids are needing, 3, 4, 5 open heart surgeries before they're into their adulthood. And everyone in this community who's on this call is all too aware of the impact of open heart surgery has on our small children. High risk of complications, long hospital stays for family, and the valve options that they do have for surgery have poor durability, and there's limited availability of these valves themselves because they're human source, so human donors. Another small child is having to die in order for us to be able to utilize their valves in this surgical setting. So not only are we talking about the burden of the surgery on the patient and on the family, but also the quality of the valve. It still doesn't kind of help solve this problem. There are a few non-surgical valve options, like a transcatheter valve replacement, but these are developed for adults. And the one thing we know about pediatrics is that our kids are not small adults, so they have their own unique needs. These adult valves are available on the market, but they're big, and so they can only fit into larger teens. So we're not solving this problem, right, for small children yet, and there's nothing on the market that is solving that problem yet. The other issue with these transcatheter valves that are available on the adult size is that they're all animal sourced, so they have high risk of endocarditis, fracturing, and they're very expensive and difficult to manufacture. So after seeing this kind of in his day-to-day clinic and with his patients over and over, JJ's interventional cardiologist decided that he, along with a team of biomedical engineers, were going to develop this pediatric-sized transcatheter pulmonary valve option for kids. And that's when Polyvascular was founded. So they've developed a solution for all of those issues that I just said, to create the first catheter valve to prevent this elimination for, or this need, sorry, for open heart surgeries. It's multiple surgeries, right? We can develop and design the valve with a polymer material instead of having to use the human tissues or animal source tissues. So I was personally motivated to kind of get involved with this team and to help see this through design and development and into the market, because this is the valve that JJ could need. And when we were sitting in that conference room 6 months ago, discussing the potential of having to replace his pulmonary valve during surgery, I knew the current market valves, the options were not ideal. So I look at this, right, on the scale of large innovation, and this small device, right, that could really drastically improve that quality of life of these kids, these young, very small children, because they now have the technology to prevent and to reduce the number of open heart surgeries. As I've worked with this team kind of from my like parent perspective and meeting with different innovators kind of in the medical device space and meeting with financial investors, I think one of the things that I really like to bring to the table is that, that patient, that family, the parent perspective is really this severity, right, of undergoing multiple open heart surgeries for a child and for the families, and the burden it places on the families, the time, the expense, and how much it impacts, really the mental health of these young children. With each open heart surgery, with each prolonged hospital stay, we're impacting our kids. So it's a voice I feel like it's very important to be heard, because it's our real life, it's our day-to-day, and it trickles into every component of life. So I have found that it's important to kind of convince people that this is something that we should be investing our time and our resources in, because we have to bring that human aspect, right, into the technology. And this is why innovation can make such a drastic difference in our lives. So this kind of leads into and connects to my next point, and really the last thing I'm going to kind of drive home this afternoon is the importance of the family and patient engagement in medtech. And we think a lot about community engagement or family and patient engagement in advocacy space or philanthropic space, and those are equally as important. But I think one area where we don't have as much presence, but we need to, is in medtech. So with medtech, I mean any device, tool, equipment used for diagnosis, monitoring, treating, anything to improve someone's health. So thinking of things like medical devices, diagnostic machines, softwares that are going to help our doctors, help our healthcare professionals provide better care to our kids. So I want to take a minute and get into a little bit more of the specifics on classes of medical devices. If we're talking about these kinds of kind of big and small innovation, right? So it's important to kind of see how these things happen, how they're developed and are approved. And so I want to kind of walk through this chart quickly. The FDA classifies medical devices into 3 regulatory classes based on their level of control that's necessary to ensure that their safety effectiveness. So these classes are determined based on their regulatory requirements that the device must go through before it can be on the market. So class 1, which is the bottom of the chart there, is your lowest risk, very general controls, things like Band-Aids, wheelchairs, tongue depressors. Class 2, the middle column there, is slightly more moderate risk, general, some more specialized controls. This requires a 510K clearance, but think of things like infusion pumps, surgical drapes, external monitors. And then we get into class 3, the top level there, which is your higher risk, and these require more stringent regulatory controls. They must undergo a pre-market approval, which it is involved with demonstrating that their safety, and most of the time that's through a clinical trial. So you can see how things like that wireless Holter would fall into class 2, and the valve we're developing with polyvascular would fall into the class 3. So the reason I say that I kind of wanted to bring this to the forefront of our attention today is because there is space and there's a need for families and patient engagement at all 3 of these levels. So the other thing I want to mention, kind of if we're talking about devices, and something that I didn't realize until I got into this work, was that there's a significant off-label use for devices in pediatrics. So devices that were designed, approved through the FDA for adult use, that our pediatric cardiologists are having to kind of come up with workarounds in order to use these devices, because there's no other option. So while off-label use can be life-saving, it carries risk because the device may not function as it's intended in the smaller body, or under kind of different conditions than those that it was designed for. So, many cases, our pediatric surgeons are left with no better alternative, and they must balance kind of these risks, right, to meet that immediate need of their patients. versus waiting for a device, the technology to catch up in the pediatric world. So the focus kind of on pediatrics and the importance of tailoring the technology, specifically to our kids is really blaring when you think about that and that gap. So involving parents and patients in medtech development is essential to ensuring that these innovations are patient-centered, that innovations are effective, and that they're responding to the real-world needs. What are these unmet needs, and how can we address them? So when I think of the multitude of ways that we as patients, caregivers, and families can bring our voice and our experience to the table, the big things that kind of pop out to me are improving the user experience, tailoring solutions to actual needs, enhancing the safety and effectiveness of the device that's being developed. Parents can play a vital role in highlighting these potential risks or difficulties that arise in the real world when we're using these devices every day. Another big thing that stands out to me in this space is building trust. When patients and families are included in the process, in this development or the design process, we're more likely to trust and adopt these new technologies. This is pediatric care, right? Where parents are often very hesitant to try new or experimental things. So early engagement can really help foster some of that sense of partnership, and it's going to share some of the responsibility and increase that confidence in the final product that you're asking us to then use, right, on our kids. And we rely on these devices, for their health. I think another important aspect is addressing the emotional and psychological factors. So a lot of these medical devices that we use can have a significant emotional impact on children and their caregivers, but parents can provide valuable insight into those emotional tolls on a device or a piece of equipment they have. Even small things, right, like the wireless halter that I mentioned before, and the anxiety and the mental load, that mental aspect that came along with wearing that device and it being so visible. And then the last thing, in my opinion, one of the most important reasons we need to have our voice heard at this table and the parent community involved in engagement in this space is to support equity and inclusion. Including a diverse range of parents and families in the development process ensures that they are equitable. Different populations have unique challenges related to affordability, cultural perspectives. All of these things are important to address in order to avoid further disparities in our healthcare delivery. So if all of those things I just mentioned are kind of like the why get involved and the importance of getting involved, I want to just give a few concrete kind of actionable items for engagement as we're kind of talking about those different classes. So for the Class 1 devices, we see a lot of benefit with user feedback, user experience. Parents can provide valuable feedback, right, on how the device performs every day. And parent and patients can help raise awareness to the community about the availability of those devices when we look at kind of more of the Class 2 and preparing the device for FDA review through that 510(k) process that I mentioned before. You can get involved in clinical testing, user trials to help ensure that the device is safe and effective for children. There's advisory panels and groups of consultants that want the patient perspective when evaluating devices, so parents can sit on those panels as well. And then when you dive kind of more into the Class 3 devices, they're more of those kind of life-supporting technologies like heart valves. Parent involvement can be very impactful at this level. One way could be through advocacy and lobbying, and advocating, right, for that faster approval process for these life-changing devices, because we need them, because there are no other options for our small kids. Participating in clinical trials, parents enrolling their children in these trials, and testimonials can also take place during the pre-market approval process with the FDA. They often hold public hearings gather input from stakeholders, and one of those stakeholders are parents. So we have to be included kind of in those conversations. We can provide testimonials about these unmet needs and really the importance of kind of pushing this work through. Once the device is approved, then you can participate in things like post-market surveillance, giving feedback for any concerns, and then of course continuing to advocate for those pediatric device needs. And then I want to just end here today. I know my focus was really kind of on our journey and then how I got into medical technology and that kind of need for innovation and how we prevent our kids from going through these unnecessary surgeries or unnecessary hardships. But I think it's important to take a moment and just state how many different ways families, caregivers, patients can really get involved and engage in advancing the care of children born with congenital heart defects. So specifically still on kind of the med side, people often ask me, besides the other ways, how, what organizations and how can we specifically get involved? And I think that companies like to listen to feedback, and you can get involved in that post, like I mentioned. But then we also have some unique groups within the U.S., these pediatric device consortiums. These are groups that work to promote the development of medical devices specifically for children, addressing the challenges unique to pediatric care. So they provide funding, mentorship, regulatory guidance to innovators that are developing, specifically developing these devices. So I have found these groups in the U.S. are very keen and open to patient involvement and that having that parent voice within, getting them involved with those innovators that are coming to the consortiums. There's also, of course, quality improvement groups, non-for-profit organizations that are raising money for research, supporting patient care. There's direct involvement with hospitals and doctors groups. So all of these, of course, are great ways that families and caregivers and patients can get involved in advancing the mission. So I wanted to just mention them before I finished. So I think that's all I have, and I'm happy to answer any questions.
Thank you so much, Katie. It was really great to hear about your personal story with your son and then also how you got engaged on the advisory side of things. One of the questions that has come up is really thinking about your own journey. What advice would you give to patients and families who maybe are at institutions that aren't currently using some of this technology? How would you advise patients or families to advocate, push the institution, for lack of a better word, to kind of investigate if these types of technologies that are available might be beneficial for their needs?
Yeah, it's a great question, and there's not an easy answer. I think that we have to start with kind of this general knowledge, this education of what's even out there. And so I think that that's something that's hard. That's a hard problem to solve itself, because how do I, sitting here at one large institution that has a lot of advances and a lot of technology, spread that word, right, to other smaller places? And so I think that there's an aspect that's almost missing there, but we need to be better as a community about kind of bringing awareness to some of these things. And then once you do know, so getting kind of more to your question, if you do know this exists and you ask your home institution, they aren't doing it, then how do you, like you said, start advocating? And I speak to, of course, having the privilege to be able to go to another institution, but being very aware that not everyone can do that. So how do you bring that in? And I think it is that advocating from a high level within your institution and potentially pulling in your cardiologist or your, your smaller group, right, within your child's care to help advocate up for you. Because those decisions are going to be made at a higher level, and it's going to take someone who understands the importance and sees the need and is making decisions on the funding, right? And so all those dynamics come into it. And so I think that you just have to use your voice and keep pushing the envelope and saying that, we need this and here's why.
Thank you. One more question for you, Katie. Thinking specifically about your work with Polyvascular, can you share with us a little bit about how Polyvascular is actively reaching out to patients and families to engage, specifically in terms of ensuring diversity of voices at the table? Yeah. So we are hearing about various different experiences.
Yeah, for sure. I mean, one of the things that we are trying to do is bring kind of awareness to the need for this type of valve, to eliminate open heart surgeries. And so we are starting to, we get a lot of questions about the population and the market size and, who this valve is going to reach. And so I think that one thing that we have done is to pull in voices from other families and kids like JJ who need this and be able to tell their story to our potential investors or people who are interested in seeing this go to market, and because you can provide a wide range, right, of people. Like, this affects everyone. This is not unique to one patient population. If you need a valve replacement, this is, these are your options. So we've been trying to gather the voices to kind of show and highlight that importance. That's probably the main way we're bringing that family voice to the table.
Thank you, Katie.
Yeah.
Thank you so much, Katie. We really appreciate you sharing
Thanks.
your personal experience. I know lots of folks in the chat, if you weren't able to see, were commenting how sweet JJ is, and I'm sure he is a thriving kiddo now. So
yeah,
thanks for sharing about your personal story and also all the exciting things you guys are working on at Polyvascular. I think the future is really bright because patients and families are really driving this work. So I hope to encourage all of you listening to continue to do so and get involved in the ways that Katie talked about.
Awesome. Thank you, guys.
So we are going to move on now to our final day one session. We're really thrilled to share more on an extremely important topic, kind of along the lines of diversity and having multiple voices at the table. There's an often overlooked group of heart families, those who are non-native English speakers. These individuals and families may have difficulty accessing credible information and navigating a lot of misinformation. There may also be some confusion or lack of information about accessing language services, or just not having the resources to even have the language resources available at their institutions. So I'd like to welcome Kristen Papa, who's a bilingual licensed psychotherapist, who's going to be sharing about how this social determinant of health can impact outcomes for heart families and tools to support them in navigating their care from the perspective of both a healthcare professional and heart families themselves. Kristen has also been working with us as an Ollie's Branch therapist, and we're so thrilled to have you here today. Kristen, thanks and welcome.
Hi, good afternoon. I just want to take this time to thank everybody to be here today. It's a pleasure and an honor to be part of this event. Like Sydney said, I'm Kristen. I'm a licensed clinical social worker. I'm a heart warrior myself. And I've had the privilege to be one of the mental health care providers with our heart warriors and families through the Ollie's Branch. So just to give a little bit of background and context about my own professional experience, I'm originally from California, but I'm currently living in Puerto Rico, where I've had the opportunity to work on the surgical unit at a local hospital here, which that's included the cardiac ICU unit and also the open heart surgery unit for almost a decade before I then started my private practice. So being in Puerto Rico, most of my professional experience has been related to working with patients and families that speak Spanish. So today I'm going to talk a little bit about supporting non-native English-speaking heart families. As healthcare professionals working with congenital heart disease patients, we face unique challenges every day. And for families who are non-native English speakers or for whom English is their second language, these challenges can be significantly magnified. So today we're just going to look at how we can incorporate cultural sensitivity into our care to better support our heart families. The families and patients that we serve come from a variety of backgrounds, each with their own languages, beliefs, and cultural practices. And so by enhancing our own cultural sensitivity, we can provide more effective, inclusive, and compassionate care to improve outcomes for our patients and our families. So obviously, one of the most immediate and critical challenges we face when working with non-native English-speaking families is the language barrier. So I want you all just to take a moment and imagine yourselves living or visiting in a place where you had limited ability to communicate in your dominant language and you or your family member potentially has a medical crisis. For many of the patients I've worked with through the Ollie's Branch program and the congenital heart disease families and patients, it's going to bring up so much anxiety and stress, and sometimes even PTSD symptoms leading up to their appointments, that if you also compound that with their difficulty in terms of being able to understand or communicate with ease or ask questions in their native language, all of that stress and anxiety is going to be magnified. So this language barrier can have profound effects on the quality of care that we provide and the outcome for our patients. According to a study by the Joint Commission, 49% of adverse events in hospitals involving patients with limited English proficiency were attributed to communication errors. So I just kind of want to go down and break and talk about some of the key areas where language barriers can really impact care. One of the first areas is diagnosis of treatment. Working in a hospital on a surgical unit for several years, I've had the opportunity to learn some of this medical terminology and jargon. But for most people, medical terms, it's a foreign language, even without the language barrier. So when explaining complex cardiac conditions or treatment options, precise language is really important because misunderstandings can lead to incorrect patient history being provided, the misinterpretation of symptoms, sometimes the confusion of treatment plans, and even the lack of informed consent. Another area where there could be confusion is related to medication adherence. All of us know that being able to take our medications as they're prescribed is really important for our cardiac care. So language barriers can result in incorrect dosing, misunderstanding of potential side effects, contraindications of certain medications and food, and even the failure to report adverse reactions. As somebody that's had 2 open heart surgeries, I know the importance of understanding and getting proper instructions regarding post-op care. And so many times that can be complicated when there is a language challenge. A lot of times I know for myself that when I'm about to be discharged or when I was working at the hospital, discharge, there's some excitement and there's also some anxiety. And so clear communication is really important for successful recovery. Potential language barriers can also lead to misunderstandings of the wound care instructions, the failure to recognize the signs of complications, potentially lack of communication regarding supervision recommendations for adult patients, and then even follow-up appointments. And lastly, I know from my own lifelong CHD care, emotional support is one of the most important aspects for both emotional and physical well-being. So dealing with a cardiac condition is really emotionally taxing, not just for the patient, but even for the family. So language barriers can increase anxiety and stress, can make it difficult for families to express their concerns and hinder the formation of trust between the healthcare providers and families. So some of the things that we're going to talk about, right, is how can we address some of these challenges and provide proactive and patient-centered care. One of the most important aspects that I've learned during my professional experience is to build rapport and to create an environment of compassion and care that's inclusive. Building rapport and taking the time to actually get to know the patients and the family can build a significant bridge despite the language differences. I think one of the simple things that we can do is even just at the beginning of an appointment, it can be helpful to explicitly name the language and the cultural differences and emphasize the importance that the family and the patient understand. By us naming it at the beginning of an appointment, it gives the patient and the family permission to speak up and even clarify any confusion that they might have. Even taking the time to just properly learn and pronounce the names of the patients and the family members can be a moment to build rapport. You know, a kind of funny story, my name's Kristen. Like I said, I live in Puerto Rico. I went and saw a physician here actually, and for whatever reason, they thought my name was Crispy. And so for many times they would call me Crispy. My last name is Papa. In Puerto Rico, that means potato. And so they would call me Crispy Papa or Crispy Potato for all of my appointments. So just taking a little bit of time, again, to be able to properly pronounce as much as we're able and build that rapport with patients, I think really can go a long way, especially when there is a language difference. Even taking the time, right, and allowing the patients and the families to be the experts in their own care, they can help us to learn some of the just basic pleasantries or greetings, or even some of the common medical terms. And that just builds empathy and support for both of us. Another strategy to build the bridge in terms of creating is incorporating clear communication techniques. So even when we're using interpreters, right, it can be really important to improve our communication. What does that mean? It's important to speak clearly and at a moderate pace. It's also important to use plain language and try to avoid medical jargon when possible. It can even really be useful to break down the information into small, manageable chunks and pause regularly so that interpreters have time to translate and for the patients to ask questions. We can even provide written summaries of some of the key points in the preferred language. When possible, using professional medical interpreters, that's always preferred. Having medical or professional medical interpreters, they offer several advantages rather than using a family member or an ad hoc solution. They can provide familiarity with medical terminology, and hopefully they're going to have the ethical training regarding confidentiality and impartiality. And sometimes they can help us navigate some of those cultural nuances. When in-person interpreters aren't available, phone and video interpretation services can be effective, especially during urgent situations. We all learn in different ways, so sometimes it can also even be helpful to use visual aids and translate some of our written materials. We can use visual tools to enhance some of their understanding, like providing or having an anatomical model of the heart, or illustrated medication schedules. Sometimes even having videos with subtitles in multiple languages can be beneficial, and we can translate the informed consents and educational materials. One thing that's important to remember is that it's not just about translation, but also ensuring that the materials are culturally appropriate. Another powerful tool to just ensure comprehension between family members and the medical providers is to practice the teach back method. A lot of times, I know many of us have had the experience where somebody's explaining something that's in an area that we don't really understand, and they ask us, do you understand? We'll just say yes, because we're feeling anxious or stressed and we want to move on. So taking the time to ask patients and family members to explain what they heard in their own words, that can be a way for us to just ensure that they're getting the information that they need. We can also use open-ended questions rather than yes or no questions, and providing extra time, being patient, and multiple opportunities for clarification, that can also really go a long way. While addressing language barriers is important, cultural sensitivity goes beyond just language. It's about also understanding and respecting cultural factors that could influence the patient's healthcare and beliefs. Some of the key areas where cultural differences can impact healthcare include health beliefs and practices, the family dynamics, cultural differences, religious and spiritual considerations. So to deepen and develop our own cultural sensitivity, it's important for all of us to practice self-awareness and even reflect on our own cultural backgrounds and biases. I'm sure most of us, especially as medical professionals, we need to continue our ongoing education. We can attend workshops, read about different cultures, and even learn from our personal or professional experiences from our patients. Let's talk about some of the practical ways of how we can incorporate cultural sensitivity into our practice. As I said before, right, building that rapport is such an important aspect. And so creating a welcoming environment is one of the first things we can do. I know in many areas, there's already hospitals that have signs in multiple languages. We can even provide quiet rooms, right, for prayer and meditation to support the spiritual practices of our patients. We can provide culturally diverse reading materials. And by building this trust and rapport, this also can be beneficial in supporting our patients' emotional well-being, since many individuals with CHD have anxiety and trauma related to their care. This can be further exacerbated, especially when they're not able to fully understand and they can't communicate with ease to their providers. Some other aspects to consider are when incorporating cultural sensitivity is to tailor treatment plans. Sometimes it's important to consider cultural and dietary restrictions and to also be flexible regarding visiting hours for family members. And if it's safe and appropriate, potentially even exploring the possibility of incorporating traditional healing practices. Many times, especially obviously with children, but even with CHD adults, I know for myself, my parents are still worried and concerned about my own care. And so sometimes it is appropriate to involve family members in care decisions. And sometimes just understanding the family's decision-making structure can be beneficial. I know for us in Puerto Rico, that's been a huge thing, is just having a time and a space for family conferences where interpreters could be present so they can ask questions. And it's not just in rounds, but it's just a formal way for us to make sure that they're understand involved, because many times it's really important to support not just the patient, but even the families. It's not just the medical team that wants to support our patients. And so it's important to remember that we're not alone in this. And we can collaborate with cultural organizations as well as community and spiritual leaders that can greatly enhance our ability to provide culturally sensitive care. We can consider partnering with local cultural centers for education and outreach, and even provide information about culturally appropriate social, support groups, especially with social media and the internet. That is just such a great tool to be able to connect families from different cultural backgrounds and get the support that they need. We can also connect with families with community resources that align with their cultural background. So providing culturally sensitive care to non-native English-speaking heart families is really important to providing effective treatment and support, not just for their medical well-being, but even for their emotional well-being. And by improving our communication strategies and incorporating sensitivity into our daily practice with our patients, we can significantly improve the experience and the outcomes of these families. So I just wanted to take the time to thank you for your time, your attention and commitment to providing the best possible care for our heart families. I know for myself, as a CHD patient, I wouldn't be here without the dedication and the care and the support I've received throughout my life. So thank you for the work that you do and for this opportunity to be here.
So much, Kristen. That was a really wonderful presentation, and you really touched on a lot of different topics and a lot of really useful information. So a few questions for you.
Sure.
What, do you feel like there are certain questions or maybe ways that providers may ask questions that care teams should avoid when working with a family when there is a language barrier?
I think in terms of ways to avoid, like sometimes I think that there's a cultural component. I know, especially down here in Puerto Rico, especially being from the States, I've learned that I can't be as direct certain times. It's really important to just kind of go slow and build rapport first and then provide the information versus coming in and then immediately starting with like, okay, this is what we're going to do. And so sometimes it's important that pacing in terms of providing information and talking with the patients. And so I think that that's important to just recognize that there are cultural differences, that living in the States, sometimes we're a little bit more direct, and sometimes that can come across as insensitive or even sometimes as rude. And so taking the time and gauging how the family's feeling or how the patient's feeling, that will kind of lend you the opportunity to determine like, okay, now I'm going to give this important information versus just jumping in there right away.
I think that's a great point, and kind of goes back to the idea of just like family-centered care in general. Like we have to interpret what the people we're working with, like how are they feeling, what's their body language, like even if we're not speaking the same language, there's a lot that's unspoken that we can really just take a moment and like observe and interpret. So another question for you, I know you didn't explicitly mention it in your talk, but I know you mentioned, leveraging translation resources and really taking advantage of that. I know we have seen and kind of the literature has shown that a lot of times providers rely on like a family member that may be present to serve as the interpreter. Can you maybe to share a little bit more about, why is that not a recommendation, and why do we really need to take advantage of those official resources, translation resources that are available to work with families?
Yeah, I think that's a good point. In my private practice, I have several clients that they are first generation. And so they talk about like that idea of being sometimes like parentified from a very young age because they are the family member that.
Sorry,
Yeah,
go
you're
ahead.
good. That's okay. And so just kind of, it's already a really stressful situation. And so sometimes it is another child or another adolescent that's available for translating for the family member, and putting them in that role of having to act as the bridge between the physicians and the parents, that can put a lot of stress and anxiety on sometimes even a child. So I think when you can include professional interpreters, it does allow for that impartiality, and it doesn't cause strain or stress for that family member to be the interpreter, because most of us don't have that knowledge in terms of the medical jargon. And so when we rely upon the family member, it's really relying on the person that doesn't have expertise possibly, or the knowledge. And so that can kind of distort some of the information. It's a little bit of that concept of just not telephone, but kind of, right? Like it gets lost sometimes when there's not just that deeper knowledge about the medical language that we could use when we have an interpreter.
Absolutely. It's such a great point. And, it may feel convenient, but it's also setting the family up, like kind of putting them at a disadvantage because they're not going to have all that information, or like you said, putting the pressure on that individual to like lead the care when they're not. Okay, one last question for you, and maybe this is one you need to think about, but what information or kind of resources do you think institutions should use to help make their facilities more culturally welcoming, or kind of do some work on their side to gain some of that knowledge or information to make the environment feel and the providers feel more capable of kind of being welcoming?
Yeah, so I think, as providers, I know for myself, like living in Puerto Rico, I would be speaking Spanish sometimes at the hospital, which isn't my first language. So sometimes just even naming that, I would tell my patients, like, look, I know sometimes my Spanish isn't perfect. If you don't understand, or if I say something wrong, like, please let me know. And so just like naming it from the beginning that there's going to be a language difference, it almost gives the patients the permission to be like, okay, I don't understand what you're telling. Versus like them like looking at me blankly and then I'm trying to like backtrack. So I think sometimes it's even more than like some of the systems we can put in place. It's just that humility of like, I'm not the expert. I'm the expert in some things. I'm not the expert in everything. And just being able to also like bring our patients in to help us in those moments, I think it can build that rapport. And then also it gives them the permissions to sometimes correct us if need be.
Yeah, absolutely. Very much agree. I think it's important to like name, hey, I may not be the expert in this, and like we're gonna figure this out together. Well, thank you so much for being here with us and for sharing your wonderful presentation and the robust discussion. This is a really important topic for us to share, so we appreciate your time chatting with us today.
Thank you so much.
So we're now going to transition, which we briefly did for a moment, but we will now fully transition to a short video. I know we referenced earlier on in the day that's going to walk you through an experience of a child and her parent interacting with the Ventripoint technology. So we will play that here now.
8-year-old Nancy was born with pulmonary atresia. She underwent surgery at just a few days old and is still monitored regularly at the East Midlands Congenital Heart Centre at the Leicester Royal Infirmary. But here, her cardiologist uses technology that's a game changer in cardiac care, and allows him to transform a 2D echocardiogram into a 3D model of her heart within minutes, and with an accuracy comparable to an MRI.
It's non-invasive, which is a reassurance. Nancy did, when she was a baby, had to have an MRI, and it meant that she had to have some dye injected so that everything showed up on the MRI. It was quite a traumatic process. So yeah, I'm thankful that we don't have to go through that every time, because we do come back between every 6 to 9 months to get a picture of what's happening.
The VMS Plus technology uses a sensor attached to the ultrasound transducer to track its spatial coordinates and orientation. A separate sensor also tracks and corrects for any patient movement.
So breathe in and out, and stop breathing and breathe away.
The software then uses a patented algorithm called KBR, which stands for Knowledge-Based Reconstruction, to reference thousands of MRI scans and create a realistic 3D model of all 4 chambers of the heart, regardless of the quality of the images or the geometries of a patient's heart.
It's quite nice because you just got to wait till they call your name, and then when it happens, it's all fine and calm.
And this technology doesn't just improve the experience and outcomes for patients, it also empowers cardiologists to diagnose and make treatment decisions faster.
In Leicester, when we've been using this system, we're able to provide a much better follow-up for these families. It allows us to track the progression of these children who otherwise I think we would be using inferior methods of looking at what is a very complicated heart structure. And one of the really exciting things that I'm starting to explore is actually taking it around the hospital. And in particular, we're starting to use it for our most sick patients who are on the intensive care unit, who actually getting that information about how well the heart is functioning can really help us with deciding on what treatment they get and hopefully improving their outcomes.
It can also be attached to any ultrasound device in any setting, and it's especially useful for evaluating the right ventricle, which is hard to image with conventional ultrasound. VMS Plus is more than just technology, it's a vision for better cardiac care, one which supports cardiologists in their decision-making and improves the clinical experience for patients and their families.
Well, with that, it is a wrap on day 1 of Take Heart 2024. We certainly have shared a meaningful afternoon together, covering a lot of really important topics. We want to thank all of our day 1 presenters for sharing their time with us and their energy and their information.
As we close out today, we'll just remind everyone that we have another great lineup of presenters tomorrow for day 2. We're going to start at 10 a.m. sharp Central Time. If you're unable to join us tomorrow, please take a few minutes to complete the evaluation form for the time you spent with us today. As we mentioned at the beginning, you can access the survey link below the slides window. We'll also be sending out an email shortly after the conference ends in a few days to be able to access that link as well. Please come back and join us tomorrow for some amazing presentations, and have a great evening.
Bye.